One, two, three. Good morning, Mr. Cody. Are you there?
I am. Can you hear me?
Mr. Cody.
Yeah. Can you hear me?
Cody, are you there? I don't hear you. Cody, try again.
Yeah. Can you hear me?
One, two.
Can you?
Hello, Cody.
Yeah. Can you hear me?
Why am I not hearing you? Can't live like this.
It may
Cannot
be my
work like
internet.
this. Can't go through this. Nope. Still don't hear you. Hang on a minute. Let me see if I can figure out if it's something in my headset. You're muted according to my buttons over here.
What about now?
Which is the sound I get when nobody wants to answer. There's no wrong answers here. I'm not going to jump on anybody. What is antimicrobial resistance?
Resistance to antimicrobial medications.
Yeah, the bugs have adapted, if you will, and they have modified themselves to be resistant to it. And that's what it means. It means the bugs have changed. The bugs have changed because we've been trying to treat it, and our treatments were killing them, and so they have morphed. They have mutated to something that we can, that the microbials can't kill. Some examples: MRSA. Do we ever run into MRSA?
All the time.
Yeah, VRE, VRSA, TB, and C. diff. All those are common antimicrobial resistant infections. And where do we see those? Well, in patients that have weakened immune system. We see those in people who have open skin wounds. We see these type of antimicrobial resistant diseases in people with recent surgeries and in people that have invasive stuff like PICC lines, IVs, indwelling catheters. So is it just localized? No. Is it just to the state of Arkansas? No. Is it just to North Arkansas? No. This is worldwide. This is worldwide. And most of these battles take place within institutions such as hospitals, clinics, A big one that we had in Jonesboro was our dialysis center. It was always coming up with some kind of antimicrobial resistant infection. So, and that goes back to the invasive procedure thing. So this is the antimicrobial resistance. What can we do with this? What do we need? Why do we need to know about this?
To be aware of uh, and possibility of catching something.
Catching something and spreading something.
Correct.
So there's two ways that we need to worry about it. We need to worry about doing our personal protective protection, gloves, washing of hands, wearing appropriate attire, and we don't have to get into a level A hazmat suit, self-contained breathing, all that. But if we wear our mask, we wear our gloves, we clean our hands. Hand washing is the number one thing that's going to kill 99% of the diseases that's out there. So we have to kind of watch out for that. Okay. All right. Any questions on antimicrobial resistance? Nope.
No.
Nope.
Thank you. We're going to go into influenza. What, why do you think we're not hearing a whole lot on influenza right now?
Because everything's COVID.
Yeah, everything's COVID. Does that mean CDC is not tracking influenza?
I'm sure they are, but they're not. I didn't. I just read about the first flu death in Arkansas a few days ago.
Well, there is the map. Can you see the map on your screen there? And you can see that the green there are the more heavier, and then the lighter greens are the lighter, and then the yellows uh, are even to the lighter side. I was trying to find out where it was at, and they have been doing a lot of tests. Um, this is data from we're in week. By the way, if you want to know, for an epidemic, we're in week number 53 of the flu season. Week 53 of the flu season. You know, it's strange when you think about the pandemic, COVID. We're in a whole lot further down than that, but you can see that we have A and B, and you can see the differences in each one of them there. It looks like B is out beating the A, which is the green here over the yellow. But these are stats that you can go out there and look at. Um, and you can see the positive specimens. I was looking down here because I knew they have deaths in here somewhere, but and maybe we're not seeing as big of move in um, flu as it was because um, yeah, it's moderate in Mississippi. Um, it's minimal in Arkansas. It's low in Mississippi. It's minimal even up in Missouri. Now, if you go to Oklahoma, it's low. Why do you think influenza is not as widespread this year in 2021 as compared to 1920 or even other years where it's been more prevalent?
Everybody's
COVID was
wearing masks.
That's it. Everybody's wearing masks. If you wear a mask, you don't spread the influenza. So if you don't want to wear a mask to keep yourself from having injuries from COVID, you don't believe that's going to happen, then yeah, you can go and look at. By the way, you click on that button on the state of Arkansas, and it takes you to the Healthy Arkansas. And I was going to look and see if it had any kind of data on influenza. Yeah, seasonal flu is right here. And there is the seasonal flu. Back up. I want to go back one because I saw just as I clicked it, I saw what it was, what weekly flu report. So remember, we're in weekly flu ending January 9th. And did you say they just had a death? Somebody said we had a death.
Yeah, I read there was one recorded, I believe.
I mean, you want to know what kind of data the state health looks at. Um, Here is even the ER visits, school absenteeism, 6.96 absent because of flu. Yeah, ER visits. Basically, there was 16,000 visits, total visits in the state of Arkansas. The complaint was flu. Here is the weekly school absenteeism. This is school absenteeism, and it looks like Perry County is the winner with 15.6. Um, Boone County was at 5.5 on flu. Um, Influenza mortality. Uh, this is an average for us. There is your hospital report. You see, it's down. Here again, it's a lot of it is down, and the reason it's down is because we're wearing masks and, washing our hands and doing what we're supposed to be doing. This is by population. Still, age 65 is not the largest number of deaths here. In 2020, positive antigens. I'm sorry. All right, there you go. It gives you an idea of flu tracking. And does EMS take part in that flu tracking? Okay, Greg, I'll let you back in again. Y'all aren't talking. I need you to speak up because I'm not gonna last the whole day. So this okay. 847-3068. Is that you, Greg?
Yeah, that's still me.
I got you twice on here.
Okay, yeah, I called in and then I joined the Zoom. Actually,
Oh,
got on the Zoom app. So
okay, good deal. Thank you. I just got you twice. I want to make sure I get everybody put in there. Jamie, are you here? I see you there.
I am. Sorry, I was late. Here,
Okay.
let me see.
You're not as late as
Can
as
you see me
another
now?
as another paramedic. Oh, I didn't need to see you. I was just wanting to let you know that I had saw you here on my screen. All right.
I'm
Uh,
here. I'm here.
Good deal. So the reason we're looking at influenza and pneumonia being down this year is we're wearing masks. Did you realize that influenza and the pneumonia virus actually is the eighth leading cause of death in the United States? That's pretty amazing. More people die from flu and pneumonia than from kidney disease or suicide. So we've already decided that the reason it's down this year is because it is spread person to person via large particular respiration droplets. So if you're 6 feet apart, you're wearing your mask, you're following good hand hygiene and uh, washing of your hands and using your hand sanitizers, then that's probably good for you because you're not going to be spreading the contaminations. Um, the flu, typical incubation period is anywhere between 1 and 4 days. So the average is about two. Um, Children tend to be more contagious for several days before they start showing signs. So kids are usually the mediators for this or the transmitters of this. And it is more dangerous to people that are immunocompromised. All right. If we're a paramedic, we should know who an immunocompromised person would be. Who would that be?
Mm-mm. Going to be your elderly patients, people with underlying health conditions, cancer patients.
Yeah, as we were saying earlier on those on the uh, immunosuppressed people, we were talking about the ones that were like getting MRSA and those sort of things, surgery patients, patients that have open wounds, patients that are on chemotherapy, patients that are going through certain types of diseases. Now, influenza vaccines are 60% effective. COVID-19 vaccines are what? How much effective?
95 after you get the second one.
Upwards to 95. So, we talk about influenza. We got to get our flu shot, got to get our flu shot. They're mandatory. They don't give us much option, but it's only 60% effective. And it depends on the flu strain. We got flu A, we got flu B right now that they'll know about, and I'm sure there's others coming out. Who makes the forecast for the flu? Who decides what flu we're going to get the vaccine for this year?
Is it put out by the CDC and the World Health Organization?
CDC, yes. I saw today on today's news the CDC people arriving in Wuhan, China to investigate COVID 19. They're there, they've been tested, they are quarantined for the next 14 days, so we won't hear from them for 14 days. Uh, but the CDC keeps a group of scientists over in China, Southeast Asia, and they're constantly looking for the next strain. See, flu comes from China or from that area. So, the flu, I guess, if you wanted to say it like a certain political person would say, the flu is really the China flu, because that's just where it comes from. So the CDC goes over there and does all this study, and then they decide which one of the flu strains is coming out, and they let the pharmaceutical people know, and they make the vaccines. So, each component is selected to protect one of the three main flu viruses, and they pick out on which one it is. And you can get information. We just clicked on the site, uh, the CDC, and you can get there and see how we're doing. And right now we are at a minimal area. Everybody in the United States is minimal, and I would imagine that's because we are, yeah, we're doing good with our masks, and we're doing good with our hand washing and our social distancing. And the only people that are not reporting any data at all is the District of Columbia, and they may have been busy doing other things up there. The Arkansas Department of Health releases their flu reports, and you can click right there. And the vaccine is available through your local flu clinic. And you can go over here, and this is always interesting to me. Over here on the left hand side of the Arkansas Department of Health screen is the communicable diseases they watch and look for and track: chickenpox, Ebola, influenza, Legionnaire's disease, measles, meningitis, mumps, norovirus, and whooping cough. Those are the communicable diseases they track. And it is the responsibility of doctors' offices and uh, healthcare institutions, hospitals, to report those to the local health unit, who reports them to the regional health unit, which reports them to the state health unit, which reports them to the CDC. And all of this is the way the epidemiologists deal with the flu and the pandemic and all that stuff. And I love the little icon over here on the left hand side. It says the flu ends with you, and that's true. And really, COVID-19 ends with you, and a lot of other places. So there you go. Um, yeah, that was where I did that one, and I got to save that one. We'll come back to that. All right, so um, let's go back to here. That's not where I was going. This is where I'm going to go. All right. Any questions on flu? Everybody gets your flu vaccine, right? You've had your flu vaccine. Most of y'all have been offered at least your COVID-19 vaccine. And I haven't heard of anybody passing away from that. So the next thing we're going to be talking about is two things a lot of people think are synonymous together, but it's sepsis, and septic shock. What is septic shock or what is sepsis? I could ask you, what is shock?
Shock is the inability of the body to perfuse oxygen to the blood, which causes your body to begin shutting down, which leads to, septic shock is that same system, but it's caused by more infection versus loss of blood or trauma.
Good answer. Good answer. Sepsis is life-threatening, it's tissue damage, and it's organs failure. It's the body's response to infection, and it is going to be the body's response. When we talk about sepsis, we're usually talking about a widespread systematic infection that has spread throughout the body. Septic shock is going to be sepsis with this refractory hypotension, which means we've got hypoperfusion. And like he said, lack of circulation out to the tissues with adequate fluid resuscitation. Your fluid resuscitation is right, but here they do not respond to fluid resuscitation because they're in septic shock. It's end organ dysfunction. It is down at the end. It is the final stop on the pathway to death. They have oglier, oh, gosh, yeah, in altered mental status. They're going to be that ogliera. Somebody say that better than me. Thank you. Did y'all hear that? What is it now? Oliguria. Oliguria. It's the production of a small amount of urine. Um, so they're making just a little bit of urine, not a whole lot. And yeah, share. Where you at? Where'd y'all go? That's it right there.
Oliguria.
Oliguria. And that is where they have intestinal organs, small amount of urine, and an altered mental status. Now, is anybody seen shock out there? Shock or septic shock or sepsis?
Yep.
Definitely seen sepsis, and I've seen what was going into leading to shock, but it wasn't classified as shock until after they arrived.
Okay. If we've seen it, did we score it with the SOFA or the SOFA score? SOFA. Did anybody know there was a SOFA score?
Nope, I've never heard of it.
Nope. I never heard of it either, but here we go. It is from the sepsis related organ failure assessment. And this is what it is. It looks at three things for the SOFA score: altered mental status, fast respiratory rate, and low blood pressure. And there is actually an app for it. And right here is the app. And is the patient in ICU? And you say yes. Do they have altered mental status? Yes. How fast are they breathing? Give me a number.
32.
Let's say 30. Yep.
30? Okay. And now somebody give me a systolic blood pressure.
Systolic pressure of 105 over 68.
Well, with a 105, the total SOFA score for this patient is 2. Is 2. This is for ICU patients. And your patient with a suspected infection in intensive care has a 13% risk of a bad outcome. So this SOFA calculator, actually calculates your outcome. So 13% risk, that means they have a 77 good outcome.
87.
87. Okay, 87% of a better outcome. So there you go. Now, if you drop that blood pressure to about, 60, it's going to make a whole lot more different. See, now we're at 23% bad outcome. But that is the SOFA score. It's used to go to measure patients that are having this um, sepsis event, and and it deals with, bless you twice, altered mental status, respiratory rate, and blood pressure. So those are the three things we look for. And if you got an altered mental state, a rapid heart rate, a low blood pressure, it's just not going to be a good outcome for these folks, especially if they are in sepsis. So that takes us to the last little bit of this lecture, or this topic presentation, because this isn't a lecture. Y'all are participating in it, not so much me. Uh, what would you say about the incidence in humans has increased in the past 2 decades of emerging effective infectious disease? Emerging infectious disease. We haven't heard of any infectious diseases that are coming out, have we?
Not at all.
No, not at
No,
all.
not at all.
Not at all.
We're all safe.
Yeah. Well, as it says here, the threats continue to increase, and we don't know what we don't know. And when this pandemic, this COVID-19 first started, there was an Ebola group that was getting together to talk about it, to share some ideas. And last Monday, a week ago, I attended one of these online classes from this group, and they actually had the medical director from St. Louis EMS on there talking about how their ambulances were handling COVID-19 and getting them to the hospital. And their average wait time in St. Louis was 2 hours. I know that Scotty and some of the powers to be with the North Arc have been telling us we need to be out of the ER by 20 minutes, but they're looking at 2 hours in St. Louis. And today they talked about news out of California where EMS trucks in California are being told, do not resuscitate this patient at the scene because we have no room for them in the hospital. So, you know, the threats are continuing. We've got this new strain now, the UK strain of this COVID-19. It doesn't run any difference in the disease, but it is more virulent. In other words, it's easier to catch. So, and these emerging infectious diseases know no national bounds. They're not just in one location. They spread throughout the world, through our jet travel and through our airline travel and through us, being around the world in 24 hours, we spread this stuff. So we have to be on guard. Our public health groups have to be geared up for it. Who is our public health folks? Who are the ones that are in charge of this?
I mean, in a way, we all are as EMS providers, just trying to contain it as much as possible. Um, but
As
if you're
yeah,
calling,
when I talk about the public health organizations, this is going to be the CDC. This is going to be the World Health Organization. Um, do they do political things? Yes, they do. But primary function, the root, if you get to the bottom roots of the CDC and the bottom roots of the WHO, they're the groups that's out there that are monitoring, they're doing their epidemiology studies, they're doing their investigations, and into these new diseases. We've had several outbreaks of Ebola in the past 2 years. And unless you are part of this Ebola group, would not even know that we've had those because they've kept them quiet because they are infectious disease outbreaks. And we are having new infections all the time, and they're trying to follow them and try to track them and try to keep a hold of them so they know what they are, where they come from. That's why one of the first things we heard about from this was the flu-like symptoms that were coming out of Wuhan, China. Here again, the WHO found out about it, started its research on it, and now it's gone worldwide. And there are still experts in epidemiology that say we don't know what we don't know because we don't know what's going to happen to these people after they get better and you know overcome it. Um, some people believe, and maybe a true fact, that it comes out of areas where they're having an ecological transformation. So the ecology is changing, and these diseases come from that ecology change. Maybe global warming, I don't know. But the results of antimicrobial resistance and a breakdown in public health measures are going to continue to see more and more emerging infectious diseases. And last week we had somebody put out there that there's a new medication out there for the treatment of COVID called benlamavir.
I just love your pronunciation, Casey.
Thank you. I have no idea what I'm calling them. I just try to write them down, try to put them through there as I can. Let me see if I can get it to say it. Uh,
It sounds like Arkansas Hick to me.
Thank you. I take Arkansas, Hick.
That's fine. It's a good language.
Well, the word of this stuff is terrible. BAMIANIVIMAB. Huh. Not even my dictionary will pronounce that one.
Hey, KC.
Yes.
One thing, going back to the sepsis, one of the things that I learned is when somebody is purely in sepsis or headed towards it, if you'll put them on even with the nasal cannula CO2, you'll notice that they're retaining CO2, so you'll have a number that's well below your 35 to 45.
All right. Good. How does that affect their blood gases?
You're going to have, CO2 adheres to red blood cells much more than oxygen will. So you're not going to get good oxygenation to your tissues. You're just carrying that CO2 around. So it's going to end up causing eventually organ failure and all tissue failure, actually.
Okay. Very good. Anybody else? Well, I'm looking for something here. Y'all hang on. I'm going to look for this. I'm going to find it. This is y'all's turn to talk. Y'all all got quiet again.
I just want to apologize for the road noise. I'm keeping my mic muted as much as possible. But, I promise in about another 45 minutes there won't be any.
Well, the thing about it is, if it gets to bother me too bad, I do have the power to mute you. What was Monday? The 11th?
Yes, it was the 11th.
That sounds about right.
Okay. All right. hang on. I'm gonna go back to sharing my screen. Y'all bear with me just a minute. Yeah. All right. Can you see the screen now?
Yes.
Okay.
Yes.
This is the grand rounds, COVID-19 ground rounds. They do this weekly, and you get an hour for going and sitting and listening to these guys talk. And this is all of the people that are. Hang on, that wasn't what I want to do. No, that ain't what I want to do either. This right here is all the people that are dealing with this, and you can see some big ones in there. NAEMT is in there. The InNet is in there. This is the doctors. This is the emergency room nurses, and it's a peer-to-peer virtual community practice. EMS medical directors, critical care challenges, health and human services outpatient therapy ministries, and emergency department. And and these are all on a Monday, and um, you can they're either a Monday, Tuesday, Wednesday, and Thursday. So every day they have one. Today they're going to have emergency physicians update, and that's going to be at 11 o'clock. If I'd have thought early enough, we could have probably dropped in on that. Um, and these are groups that you can go in and listen to. Um, I was going to try to send y'all a link if anybody was interested in in getting in touch with these people. They come out of the University of New Mexico, um, and I'll send this right here in the chat. Um, that way, you guys, if you wanted to, come on, if you wanted to happen to, you'll send an email to that address right there and say, please include me in the grand rounds COVID-19 weekly grand rounds. They will put you on the list and you can go there and register. And you get an hour for doing it. And if you just attend 12 of these, which would be 12 weeks, you would have your 12 extra hours you need for your EMS part. And they don't talk over your head. In fact, one of the neat things about the grand rounds this week with these medical directors were um, looking at uh, um, a workforce multiplier. In other words, they were discussing the fact that there's not enough people out there to give these injections, the COVID-19 vaccines. They didn't have enough people, so they were looking at workforce multipliers, and they were bringing in paramedics to actually give the shots. And that was an interesting thing. And they're doing that in Missouri, and they're even treating their basic EMTs to give these inoculations. So they're they're doing some just-in-time training. They were doing other things that were interesting about using basic trucks and paramedic truck backups. They were talking about how they were dealing with the different types of PPEs they used. It was just really interesting to hear them talk about it. They were talking about the telemedicine and how telemedicine is now part of EMS. And this guy really said something I really like. Occasionally I get a pearl from these guys, and this was a true pearl. He said, we have always thought of in the past, before COVID 19, that EMS took patients to health care. He said, now we realize that EMS is health care. So healthcare is EMS, and we're not taking them to the hospital. We are part of that healthcare system, and we need to be treated as such. He also talked about sharing monies, getting the folks to CMS to pay for going out, looking at patients and saying, you really don't need to go to the hospital. You're not too sick or you're not sick enough. And we're going to let you go on and stay here with certain parameters. And the problem is if EMS doesn't transport, EMS does not receive reimbursement. And isn't that what it's about, getting our money?
I think that, and also taking us away out of the risk factor part of things, to where, if something goes wrong, with any of these patients. Well, we did our part and we transported them. So now the shoe's on somebody else's foot
Well,
if this patient dies. And that, I think that's a part of it as well. Of course, money is always the biggest issue, or everybody wants their money. But, it's also, I think it also has a little bit to do with the other.
Well, yeah, but when you deal with a patient and you go out there and you check them, and you've got a feeling in your gut, you got a feeling this person does not need to go to the hospital, and we've got the perfect out by contacting our med control and getting them to say, yep, this person doesn't need to come. We're backed up here. They're going to wait here forever. They're going to be they're going to be involved in a high risk, possibly spreader event if they come in. So that's the other part of it. And that's something that we can do as EMS and things that we can work on. All right. And that's with our EMS medical partners, our medical control.
Right, but doesn't that also come down to, I mean, if you look at how many patients try to avoid calling EMS by calling the hospital to talk, or calling the doctor's office to talk to the nurse on duty or whatever, and they refuse to give them, I'm sorry, I can't give you that kind of an answer over the phone. You just need to come in and be seen, And so it still puts it down to, so some of these people that are calling to talk to the doctor's nurse are just being told, you need to go to the ER. Yeah. If it's outside of, the hours, and right now, while I was streaming, I was hearing so often that the doctor's offices, so if anybody clicked off any of the COVID symptom checklists, they were told they could not come into the office. They could set up maybe a telehealth, but that they really just needed to go to the ER. And we all know that, through the years, go to the ER means, oh my God, you're going to die. You better call an ambulance right now. Not get in your car and go to the ER. Or they're not even giving them, any kind of, well, yeah, we don't want you in our office because we think you have COVID. But go ahead and walk yourself into the ER instead of, well, here's the thing, you've got this X, Y, and Z COVID symptom, so we're unable to see you in office. So, if you are having this symptom and this symptom, then, you're better off to go to the ER. But when you get there, stay in your car, call this number, they'll come out and screen you there, and then, be able to bring you in. Everybody needs to get on board, and that's just not happening. But there's still, the people that do try to do that and avoid using EMS and the ER are still being told that that's exactly what they need to do because somebody's not going to give them any advice over the telephone.
Yep, and then they are savvy enough to know if I have to go up there by car, then I got to sit in my car. I've got to be screened in my car. So if I call EMS, they just take me through the back door.
Exactly.
Yep.
There's been a lot of calls that fielded that they call their doctor's office and they say, we can't tell you, call 911.
Yeah, and that ain't right, is it, Cody?
No, I don't think it is, because majority of those with COVID, a lot of them weren't even meet the criteria of coming in. They were satting fine, not, I mean, they weren't satting normal, but they were within bounds of not having to come in, basically.
Right. And that's what they're doing in California. I'm sorry, go ahead, Greg.
One of the issues I've ran into while contacting the med control room is the doctor telling me, well, I'm not going to give advice over the phone. If they want to come to the hospital, just bring them to the hospital. Well, I mean, that's not always the best option, but I mean, if that's what your med control is telling you, I mean, it's just making a mess, a small mess, a bigger mess.
Well, if they tell you we're not going to give you any advice over the radio or phone, just bring them in. You know what you say to that, right?
Yes, sir.
Yes, sir, transporting. And then it becomes their problem when they get in. We tried. That's all we can do is try. And a lot of this will develop by education. A lot of this will develop because bigger cities are going to, bigger services will start implementing different plans. And a lot of times in EMS, our movement, our treatment protocols transfer from high volume services to low volume services, where it really should be low volume services should be pushing the high volume service. Not always the case, and that's a that's a prime example of that. Okay, next thing we're talking about is pain management. Yeah, there is some policy statements out there. This is a policy statement from who was this? From the American College of Emergency Physicians, and this is the ACEP board of 2015, and they're talking about out of hospital analgesic and sedation. Excuse me, it's talking about what we do out there in giving medications and how we deal with pain management. And I was looking for their this is their ideas right here. EMS medical directions should consider the following concerning provisional out of hospital analgesics. Nonsteroidal anti-inflammatory acetaminophen have well studied, so we should be able to give those out there in the field without any problem. Opioids are the mainstay of out of hospital analgesics. Morphine and fentanyl are safe and effective. Fentanyl's rapid onset, short duration, says that's probably pretty good, and they kind of like it. EMS medical directors should consider the following for the use of out of hospital sedations: anxiety, agitation, and then most benzodiazepines, the Valiums, are safe, but the pharmacokinetics of midazolam make it an optimal agent for out of hospital management of anxiety and moderate agitation. So they say, yeah, we probably should do that, and that's good. Ketamines administered in dissociative dosages can provide rapid onset for chemical sedation. So they said that's a good one for us to use. And then benzodiazepines in violent patients is a good idea. But that is the policy statement right there from the ACEP folks on treatment for using analgesics in pre-hospital settings. Now, hang on a minute. I'm going to stop sharing. And I'm going to just throw out a question here. What do y'all think? How do y'all think we do with chest pain patients? Do you think we actually take care of chest pain patients? Do you think we use a lot of sedation, painkillers, pain control? Do we use that a lot in our chest pain patients?
Depending on
I don't think we do.
chest pain.
Somebody said, I don't think we do. What was the other one here?
Depending on the origin of chest pain, I mean, determines how it's treated. If you're talking chest pain because of respiratory issues, probably not going to throw, analgesics at it. But if you're talking about cardiac chest pain, I mean, it's basically what's going to be the best for your patient. If nitro doesn't take care of the pain, yeah, go with, morphine or fentanyl for it.
If you're looking at your screen, you're looking at a spreadsheet, which are the 2020 chest pain averages. This was just out in January the 5th. We had a total of 415 chest pain patients. 80 of those were interfacility transports. 302 were urgent chest pain patients. We did SpO2s on 100% of them. We had 91% 12 lead EKGs and 10% 4 lead EKG. 95% of them got IVs. Just a little over 58% got aspirin. And if you add in the aspirin prior to our arrival, that puts us up over 63%. Nitro was given in 53% of the patients. If you add the 4% before, so that's 57%. But morphine and pain control, only 27% of our chest pain patients receive that.
I think it's a little shocking at the, just over 50% with the aspirin and nitro. But again, we get called for chest pain, or how the dispatch works as far as, they say chest pain, where, once we get on scene or we get with the patient and their chest pain is actually something respiratory in nature, or, non cardiac chest pain. So, if we're talking like true cardiac chest pain, those numbers are shocking to me. But again, it's such a blanket call for help
Well,
that,
if
it encompasses such a large group of people. And, just like our, unresponsive. Okay, well, or they ain't acting right. Okay, they ain't acting right goes all the way from completely unresponsive, no, they ain't acting right, they ain't acting at all, to a, a psych patient, that could be suicidal or homicidal, that ain't acting right. So an altered mental status call can go so many different directions. I believe that's the same way with chest pain.
well,
So is
these
this
chest pains here are actually chest pains that are cardiac in nature, and they're not albuterol is not on here because they didn't get it. These were actual chest pain patients where they received the nitro. They got 12 EKGs. If we did 90% of the runs had 90% of the runs had 12 lead EKGs, we were looking at chest pain as a true problem, giving them
well,
aspirin
then
and
I am
nitro. Yeah, 27%.
that those numbers are absolutely shocking to me if
Yep,
they're cardiac chest pains.
they are cardiac chest pains. And 27, a third of these patients. And a lot of times we are guilty, and this is where we're going with this part of this program, this the analgesic. We get the patient's pain under a 5, we're happy. Should we be happy at a 5, less than a 5?
I would like that I don't have the patient be in pain at all.
Yeah, that's our goal, is a 0 pain number. But it seems that we get them under a 5, under a 6, and we don't want to go on and give morphine or fentanyl. Why is that? Are we afraid we're going to put them into making them fentanyl addicts, morphine fiends? Or is that why we don't? Why only 27% of our patients receive this medication? Is it because we're at the hospital already and they don't? We're outside our time frame of getting it. I don't know. It's just an interesting number to me. And this is the 2020 averages. I could go back and pull up the 2019 averages. And I'm going to stop sharing here just a minute because I am going to go out there. I want to see it because I think I can do that one. Uh, y'all, hang with me a minute.
One thing I'm curious about is what was their pain level after? I mean, you said 57% took nitro. What was the pain level after they took the nitro? I mean, if they say I don't have any pain now,
No,
probably not good pain.
the pain continued in most of these patients. Um, and I was looking here at, let me share you this one. This is for 2018. I did not see the 2019 study in front of me, but the part I'm going to share with you Look over here. The Arkansas CDC says pain medication 95% of the time, pain medication 91% of the time, and we're falling at 27%. We are far below the national average on that. So and this one was 25% here for that sheet. So anyway, it's not telling stuff out of school when you show stuff like this. It is just really interesting to me that we we don't we don't work our patients till they're pain free, and that I don't believe is a correct way to do it, in my personal opinion. I know if I want to be if I am having problems, I want to be pain free. Hmm. Y'all have gotten quiet on me again.
My question, since this is out of my scope of practice, as far as what we're talking about, what's preventing that? What's keeping us at that percentage? Is it medic personal preference or a protocol?
Well, it wouldn't be protocol, would it?
Well, actually, I don't know what our protocol is on that. I'm not at that level, so I don't know what our protocol is on usage of morphine for chest pains.
Okay. Protocol says you need to get them to zero pain tolerance. Now, I will say this from 2019 numbers, here's 2019 numbers right here. We're up. We're up from 22% to 27%. So 5% increase over 12 months. That's not too bad. Our aspirin is down though, because there it is 70. We were at 76% last year for 19, 2 years ago, and then nitro we were at 56%. So
Casey, I will say on the dispatch side of things that we do incorporate aspirin diagnosis tool in our EMD. So we do give instructions on aspirin administration over the phone prior to the arrival.
well, that's good. And that's one of the reasons why, if you look at our data here, aspirin prior to arrival, okay, right there, we're at 14% there. And if we go to the 2021, we're at 5%. So we went down with aspirin. So, we were doing better in 2019 than we did last year for aspirin prior to arrival. It's just, statistics is interesting to me, because I guess that's what I do. So I see all this stuff, and it is just interesting. And I need to put all this stuff and send it to somebody together. Hmm. Okay. Questions, comments. It's interesting to look at some of this. Um, because it is looking at all these. All right, let's take a short break. We'll be back in 20 minutes. How about at 9:20 we start back? Okay.
Okay,
Sounds good. See you then.
All right. Time to get a coffee break.
Hey, Jamie.
Yes, sir.
Have you applied for your park medic yet?
No, I didn't know anything about it.
Okay, so the whole process, I just got my park EMT. It's a separate application. It allows you to get it turned in for SRT, TRT. Have you done that?
I honestly, I don't know. I haven't, probably not. I haven't done anything like, the last thing I had was, what is it, my gray card or whatever with Busar.
Yeah, that's me. I haven't done nothing with it. Now it's all on red card, and I just started the process to change
Or maybe,
it.
yeah, or maybe it's my red card. I don't know exactly what it is that I've got taken care of, but I know it does list me as a medic on that.
Yeah, but I still think you have to get a different. So EICC, who coordinates all that stuff, has moved from Shenandoah to Harper's Ferry, and
Uh-huh.
everything's changed so much since all this started. Because Colleen's no longer at Park Service. She usually did the IQCS stuff, so now Finn's doing it. But anyways, I'll email you the application. They get you in the National Park Service EMS system, and they send you credentials. So I've already sent the
Okay.
application to Charlie, and I'll email it to you as well.
Okay, I appreciate that. Yeah, and then if I have any questions or whatever, I probably need to call you or get with you and see what all I've missed here in the last year or so.
Well, there hasn't been much going on with COVID. Billy Bell's no longer at Park Service, so he's no longer the STAR coordinator. Danny is now in charge of that. Now he's also the EMS coordinator for Part 2. So, but yeah, as far as what's going on, you and I are the same boat because nothing's really been going on. So, but I'll email that.
Yeah. Okay. You're kind of cutting out a little bit. I don't know if it's you or me.
It's
but
probably
I'll get with you.
Very good internet at the house. It has its days.
Yeah, my Wi-Fi has been going in and out since yesterday. It's been so windy up here on the mountain that, like my TV won't come on right now. I've just got a spinning circle because the Wi-Fi keeps going back and forth.
Well, that's like I got an Wi-Fi extender downstairs, and it don't like to play nice sometimes. That's probably what's causing it.
Yeah. All right, cool. Well, yeah, email that to me, and then I'll get that filled in. I guess it says on there who to submit it to and that.
I'll include the Wi-Fi or the
Okay.
email to go to.
Okay, cool. That sounds awesome. Are you still there?
Well, everybody back?
Never left.
Never left. Well, I'm glad you didn't leave us.
Casey, my fiance told me to tell you hi. She used to be one of your students.
Oh, which one was she?
She was one of your EMT students, Katrina Ordinero.
Oh, okay. I remember Kat.
Yeah, she said she was up to some shenanigans in your class.
Yeah, she was a wee bit of a, yeah,
Yeah,
just enough
she
said
still
about
is.
that.
She still is.
There you go. Well, as soon as I make sure.
I'm here. Hey, Casey.
Yes, Jamie.
Cody was. I just got a message from Cody. He's having internet issues. He asked me to let you know that he's rejoining on his laptop. So I don't know if you need to let him back in.
I just did.
Okay, awesome. Thank you.
Yeah, I have to watch for
And
those.
I'm here for Casey. I just
They don't pop up.
Yeah, I remember the last time. Yeah, I remember the last time that I got out of the meeting and came back after lunch. You had to physically let me back in. So.
Yeah, we're not blocking people from getting back in, but sometimes it's a little tougher because they don't just pop up here and say somebody's wanting to get in. You got to go to their attendance screen, and that's something I'm going to do right now is take attendance. So y'all bear with me just a minute while I do a screen capture.
And Casey, I'm having a little bit of difficulty. I'm having to navigate between patients too. So
Okay.
sorry about that.
Well, as long as you're on this screen clipping right here, then we'll be
Yeah,
okay.
hopefully I won't lose you. It's so windy up on the mountain. My Wi-Fi's been giving me fits since last night.
Yeah,
So it's off and on constantly. So I'm hoping that if I lose Wi-Fi that it kicks back over since I'm on my phone to data, but there's no telling. I mean, my TV won't even come in right now. It's off and on, and
I understand.
my Wi-Fi is just not happy.
Okay. Now, Greg, is your number 473? Excuse me, 847-3068, right?
Yes, sir. That's my number.
Okay, because I got that number, but I didn't know. I'll make sure that's put in there.
Once I get to the house, I'll probably switch over to the Wi-Fi and disconnect the phone call, but just stay on the Zoom app.
Okay, I think we're okay right now. I just took attendance, so. And the way I do that is I go to the screenshot, shows everybody there, and then copy it. Okay, so as we start this pain assessment, adequate pain control is not routinely provided for a number of reasons. The number one reason we don't give adequate pain control is underestimating the patient's need. How do you feel about that?
I would say that's probably accurate. We look at we tend to look at vital signs and say, well, their vital signs aren't indicating they're in pain, so they don't need any pain medication.
Right?
I would agree with that.
Good.
And then we have our chronic pain people as well that their doctors are cutting them down, so they'll call us. And as the longer you're here, the harder it is to trust that what somebody's telling you as far as their pain level, especially when they don't look like they're in pain. I mean, that's one of those things we can't measure. you have to go by what they tell you, and people's pain tolerances are so different and widespread.
You go from gender to gender, it's different.
Huh.
Right. You know, men don't
Well,
tolerate pain
we
as
all
well as
know that.
ladies.
No, I was just gonna say we all know that men are big old babies. So.
True. I'll agree with that. I resemble that remark. So, uh,
Hey, in my defense, I took a 15-foot fall and didn't go to the hospital, so I'd say I have a pretty decently high pain tolerance.
I agree.
I think that tolerance is in your brain, Greg. That's not a pain tolerance. That's either it's one S or another, either scared, silly, or stupid.
EMS personnel may base their judgment on past or similar patients. Do we rate patients between each other?
Yeah, it's a common deal.
Yep, pretty common. You know, we see this patient and they go, oh yeah, this patient here was working me for those pain meds, so this patient here is working me for pain meds too. You know, and we tend to lump them all in the same category. So, protocols. What does our protocol say about pain management?
To take care of the patient's pain based on what the patient tells you.
Yeah, that's true. So it should be a severity, and we usually use that 1 to 10 scale, with 10 being the worst pain you ever had in your life, and that doesn't work, does it?
No, because then you get numbers like it's 25, and they're laughing and texting on the phone.
Mm-hmm. Then how do you take that?
That you're not really in any pain.
That's true.
But you know what? I think that we also assess pain management the opposite way as well, because you know, if you've got grandma with a hip fracture and she's saying, no, I don't need pain management, you know, I don't need any pain meds, I'm okay, and we're looking at them going, oh my God, no, that has got to hurt like crazy, I'm going to give you something.
Yep, true. My mother-in-law just went through a fractured ankle from a car accident she was in. She was up walking around on it and had no pain whatsoever. Go figure.
Yeah, so I mean, I think that, again, it's a judgment call, unfortunately, because if we listen to every one of our patients, we've got the ones that maybe don't want any narcotic pain meds because they're scared of it or whatever else. So, you know, you've got to be able to trust your patients, and that's not always easy to do.
Or always good to do. You know? Very
exactly.
True. Very true. So, you're still saying that we got to trust our patients. So it's still a subjective call on our part, right?
Right.
It would be great to be able to attach some leads to them and go, my pain meter shows you're in severe pain.
Right. But you know, no, but like Greg also, you know, said earlier about, you know, vital signs and different things that we know that are going to show that, yeah, they're probably in some pain. You know, we can tell by their actions, how they're looking, what their vital signs say. You know, okay, well, you're probably having a pain response.
So
but those tools are not always there.
So there's physiologic and psychological and emotional, correct?
Yeah.
And behavioral. Some people act different in pain.
Absolutely.
So we have to document the presence of pain, the intensity based on the patient's scale, and any change of that. And when we get a change in the pain scale, whether it be worse or better, what is our ultimate goal?
To make it better.
To make it zero. Because why does pain really affect our patients' outcomes?
Yes, I mean, pain is a stressor. Stressors affect, even good stressors affect everything. It's going to affect respirations, heart rate, and if you got somebody that's in pain and their heart rate increases and they're a major trauma, well, not only are you just pumping out the blood quicker, you're causing even more pain.
And you're causing an increased myocardial demand, which means if they're having a heart attack, they could extend that heart attack. So we need to get these patients to zero. Now, with pediatrics, we don't ask them about 0 to 10. We ask them about the faces of Wong or Wong's faces.
Yes.
Wong Baker faces. I'll open this tab up so you can see it. And that is the Wong Baker faces, where you give them the faces and say, point to how you feel. And you can see 4 to 6 is kind of a little, not much change, but 10 is crying, hurts worse, no pain is 0, and we use those as our scale. All right, so we get that, and we got to understand that there are indications and contraindications to each form of analgesia, and that was what that ACEP paper was earlier. And it should follow protocols from our local and regional trauma centers and opinions of our medical Medline control. All right. So careful use of appropriate wording, non-pharmacological. Are there some non-pharmacological interventions for pain management?
Yeah, positioning.
Positioning, yeah, that's non-pharmacological.
Of course. I'm using that at home with my kid that just had surgery, and ice packs. I think that we don't use ice packs enough.
Distraction. I got a friend of mine that does magic, and he'll do
Oh
something with
wow.
his hands, and it just distracts the patient from the pain. If they're watching something out the window or reading something that distracts them from the pain, as long as they're sitting there thinking about the pain, it's going to what?
It's going to increase
Yeah, it's
or
going to
keep going. It'll
get it.
always be
Yep,
there.
there you go. So distraction
It's going
works.
to persist.
Absolutely. Parents, here's one. Parents' presence typically reduces the level of stress in kids. That's true if the parents, aren't stressing themselves, because the kids then will
Yeah, I was
mirror
just
what
going to
their
say,
parents are. Yep. Um, immobilization of fractures, that's always good. Elevation, ice, that's the one you talked about. And padding of spinal immobilization. You put them on a spine board, please pad them, pad those voids, makes them feel better. All right. So when we get into pharmacological interventions, here's the stuff we typically use: narcotics, ketamine, nitrous oxide, Nubane, and NICEDs. So morphine, fentanyl, this is the one we looked at for cardiac patients only about 27% of the time this year, about 22% of the time last year. Uh, you know, I'm not sure why we don't use that. And I guess maybe we need to drill down on our data to see if the reasons we didn't use that was how many of these patients had 0 pain after they received the aspirin and the nitro. I had not thought of that until you guys brought that up.
yeah.
Good point.
So probably need to add a stat line in there.
Yep, true. Ketamine. What do we use ketamine for?
That may
It
depend
can
on
be
who you
used
ask.
for excited delirium or pain that's refractory to, you have, your pain meds, your other pain meds aren't working. Ketamine is your last, next resort.
Sure. Somebody was calling that vitamin K the other day. Let me give you another one that somebody sent me in a text. Hang on a minute.
Casey, that might have been me. Can you hear me?
Yeah, I can hear you now.
Okay, yeah, my microphone on my laptop's not working for some reason, so I had to get my other one.
Okay, we're glad you did that. Y'all seeing my screen?
Yes, sir.
Shortly.
Okay.
Yes.
Casey, I got my screen shut off, so I got booted out of the.
Okay, I'm putting you back in. Here is the
All right,
new
thanks,
one.
sir.
Here is the new one that they're using in Australia that is coming to someplace near you. It's going to be called the green whistle.
The green whistle.
Is this going to turn into our new what you call it? Oh, for Pete's sake.
It's Penthrox,
Uh,
Penthrox. It's self-administered analgesic agent, short-term pain relief. It has been used in Australia for the past 30 years, and now it's available in Europe and Canada, and soon coming to a Walgreens near you.
wow.
It gives continuous inhalation and provides analgesia relief for 25 to 30 minutes or up to an hour when you give it intermittently. Kind of an interesting. Somebody brought that up, and I went, "Pain green whistle." I'd never heard of such, but there it is.
So methadone is what I was thinking. Is this going to turn into our new methadone?
I don't know.
We're trying to get, because that was one of the things when I moved out here and seeing patients with methadone on their regular med list. I was asking my patients, well, when did you get off heroin? And they're like, what? Because in California, methadone was used to kick heroin.
Right?
So it seems like now, with them trying to get so many pain management, chronic pain management patients off of their narcotic meds, this seems like something that they would do, like a new methadone. You know what I mean?
Right. This is just ease of action, rapid onset, short term, and so it takes the place of any of the opioids. So there you go. Green whistle. Uh, the person that told us about it in the last class said they were using it for jellyfish stings and as a pain
Huh.
mechanism. So there you go. But it's not
So is it
known.
inhalation?
Yep. It's. Can you see the screen? Did you see the screen?
Yeah. So that's why when I got to see it a little closer.
It's just a whistle. You take this, you put it in here, and somehow it reacts to that, and you breathe that in. It's a green whistle. That's what it is.
Huh.
And if you breathe hard and fast, 25 minutes. If you intermittently use it, it can go up to an hour of pain relief.
Interesting.
And I don't think it has according to the 30-year use of it out there in Australia, it doesn't show any signs of addiction.
So if they've been using this for 30 years in Australia, why has it not made it here? Or why are we not using it?
Probably because it's not an American drug. I'm thinking, I don't know. I could be a little bit of a conspiracy theory on that. Um, you know,
But I mean, that seems like a better alternative to the doctors trying to cut our patients down to where they don't have any pain control at all.
oh yeah, I understand.
You know, they're saying that we're having an opioid crisis here. Well, then what's our alternative? That seems like an alternative to me. So why balk at that?
Money.
I tried to say that in a
Yeah.
nice sort of way. And of course, it's not gone. It hasn't gone through our. It's not a controlled substance. That's the thing that gets me right there. Um, metho, yeah, whatever that is. There you go. That's from the emergency field guide for it. Not a controlled drugs. Benefits are rapid onset. Man, I think we ought to get some of this stuff. And that's an Australia report too.
Well, and that's probably the problem is it's not a controlled drug. Therefore, you don't have to go to the doctor to get a prescription for it. So money.
I think you're right. I think you're right. Anyway, that is Penthrox, Penthrox. Watch for the green whistle near you. So, with monitoring and documentation before and after analgesic administration, we've got to make sure that the patient's clinical status before we give them an analgesic and after. The level, we need level of consciousness, heart rate, blood pressure as a baseline, and then following each intervention. That's the thing that gets us about on not doing ongoing assessment when we're giving medications. We need to document what happened, what corrective action, and we need to follow our quality improvement and medical oversights, tracking plan, feedback, chronic versus acute. You know, the acute ones, they don't have the baselines that we need. Acute, we're trying to get them to zero. Chronic, they may be happy with the two. They may be happy with the three if they get it that low. They can't have dependence on this stuff, um, and prescribed medications. So you need to make sure you do your pain assessment before and after and see if it's doing some better. Um, pain is individualized. What's a five to me might only be a three to somebody else, which might be a nine to somebody else. So we got to be careful. It's not our bias that affects our treatment. So we got to make sure that that's not going on. All right. Um, did anybody want that information on the green whistle? Or you guys can search it as well as I can. So NISODs are good. We should use the acetaminophen and aspirin. Um, and we can use those with opioids. That's your Tylenol 2, 3s, and 4s. Um, fentanyl is an ideal narcotic agent. Why would they say fentanyl is an ideal narcotic agent?
Probably because it wears off so quickly. So once we get to
Right?
the hospital or whatever, they can do their own assessment.
It doesn't mask anything short term. Short term. Um,
Right.
Sometimes there's a fear in clouding the ultimate diagnosis when we use analgesic. I mean, we've been told for years, don't give them analgesics because it's going to mask their abdominal pain. It's going to mask this pain. It's going to mask that pain. And in actuality, if we use the right medications, it's short lived and we won't be masking anything. Okay. Here comes somebody. They're going to say something. I guess not. Okay. So how about midazolam? Anybody like using that?
For persistent seizures, yeah, I like using that. For I've never used it for pain, but wouldn't Ativan be a shorter acting way to go
Yeah.
on that?
Yes, it would. Okay. But we use the Versed in ways to help, forgetting. If you don't want them to remember, you know, if you don't want them to remember, you want them to forget. Remember Versed. That's what I'm trying to say. Again, there's other agents for that. Um, we talked about the Wong faces, and then there's some more faces. There's even got one out there. I love this one, and it's not found out there anymore, unfortunately. It is the Oucher scale, which is used for pediatrics. There we go. I'm trying to get to here. We are. And then there are, when we get into um, pediatrics, real babies, small babies stuff, we don't we're not able to. Okay, you're going to be that way, are you? The flax scale. There's a whole bunch of them, and I think this is the one we looked at last time. This is for the little bitty tiny babies. You look at face, legs, activity, cry, and consolability, and you scale them on a 0, 1, or 2. Um, if they frequently consistent frown, clenched teeth, quivering chin, that's a 2. If they have no particular expression at all, that's a 0. So the higher the number, the higher their pain level. If they can't console them at all, that's a 2. If they're crying, screaming, sobbing, if they have an arch, rigid back or activity, if they're kicking and their legs drawn up, yep. That we've all seen babies that have a 2. Um, and we deal with these, and the higher their number, the higher they are in pain. Um, so if you get a 7 to 10, you're in a severe discomfort. And I think we've all seen kids that way. Did I hang up on everybody? Y'all all got quiet for some reason.
Nope, we're here. I'm
Okay,
here.
good, good. I'm glad you are, because I didn't have anybody talking, and I didn't have any hissing in my ear, and I didn't know what to think about this.
Sorry, Casey, I muted because I didn't think you'd want to hear me chewing on food.
It might be interesting to hear. I don't know. All right.
No, I appreciate that, Greg.
He does. She does. Y'all ever heard of the flax scale?
I have
Nope,
not.
I haven't.
Okay.
New to me.
Well, there you go. So that's the price of admission here today. I'm sorry, I'm doing something here. I'm copying it down so I can share it with you. And this goes from ages 2 months to 7 years. So this would give you an opportunity to check those kids out that are a wee bit smaller, and it's hard for us to really understand what they're after anyway. Um, the non-invasive we talked about already. Distraction, alternative strips versus sutures, topical and regional activities where we give medications at the room temperature, unlike the vaccine that's given at minus 90. Skin simulation, oral and liquids, are usually sufficient. These are the NICEADs, kids that we don't give analgesics to. Intranasal, the oral is good. Intranasals might be a little more effective, less intrusive, easy, quick. You know, even we can reverse it if we give them too much of that. Yeah. Anything else on pain management? Remember, fentanyl, ketamine, and Toradol can all go up the nose.
I think it's kind of funny that they're saying intranasal might be is easier.
Yeah.
That probably comes from somebody that's never dealt with a baby. Even trying to take a temperature,
Well, yeah.
just a quick scan, they're always quick to turn that head away,
They don't
pull
like it.
away from you.
They are
No,
be away from you. It's true.
that could be quite the wrestling match.
Can be. But if you think about the wrestling match for that compared to
True enough.
IV,
With a sharp needle.
yeah,
Uh huh.
the nose is going to be much easier. Um,
Indeed.
they also have this is a pediatric pain and anxiety reduction. This is out there by the American College of Emergency Physicians. Uh, Pretty easy read. And if you guys want to get to any of this stuff right here is directly off of you go to the National Registry website and you click on your certification level, put recertification, scroll to the bottom, go to the NCC NRP guide. There's the guide. You can go to pain management, which is right here. There it is. Click on that, and now you're right where I'm at.
Cool.
So these resources, after I get off the line with you, if you want to go back in and say, what did he say about that? You can go in there and click it and look at it. All right. So
Awesome. Thank you.
you're welcome. And today is the beginning of the Arkansas EMT Association's virtual conference. They're having a virtual conference today and tomorrow and Saturday. And it's only $100 and you get 23 CEU units, I believe. Uh, haven't made my decision if I'm going to go get on that or not tomorrow. Got some things.
They're also offering it again in 2 weeks, I believe.
Yeah, you're well.
Yeah.
Any of the classes will be online for 2 weeks, so you can go back and watch them in 2 weeks and still get the credits for them. So yes, $100, not a bad expenditure of funds, and you don't have to have a hotel room, and you don't have to travel, and you don't have to sit in lecture labs. You can let me do this. You can sit in. Y'all can all see me now. You can sit in your recliner and listen to the conference and be very engaged. Oh, y'all still there? Okay, questions on pain management. Going, and we're fixing to go to something new. Yeah. Yep. What do you think we're going to next? One of the things y'all make a lot of runs with.
Abdominal pain,
No.
psych.
Psych. Yeah. There you go. Psychiatric and behavioral emergencies. Y'all definitely make a few of those because I know I definitely read charts off of those. And we need to look at the components of mental status examination. How can you tell they got an altered mental status? How can you tell that they're acting differently or oddly or more uh, strange?
Well,
Well,
family or friends are going to be a big tool there. But I mean, if it's somebody we go out to that, is out in the public or lives alone or whatever, I think you just have to go by the norms of society.
this is true. If they're sitting there in their birthday suit and they're in their own house and they are a naturalist, then that might be a norm for them. May not be crazy, but if they're sitting in Walmart at the food court in their birthday suit, that is a little bit strange. What can cause their mental status to be changed? What type of things can cause changes in their mental status?
Infection,
Ooh,
diabetes.
Infection,
Um,
diabetes. Yep, those are all good ones.
non-compliance with medications.
Non-compliance with medications. Yes, definitely will. Amanda, can you give me any that's on the screen, maybe?
Um, If they're altered mental status, I mean, anything from urinary tract infection to a bump on the head.
Head injury. Yes. Hypoglycemia, diabetics. Yes. Hypoxia, lack of oxygen. Yes. Stroke, and even dementia. Do we have patients that have dementia? You betcha. We see those. And even medication side effects can cause mentation changes. We need to look at their mental health history. Have they had any problems? As we said, we need to go by, or I didn't say, but Jamie said, their general appearance, their dress, their grooming, their posture, how they make it, what's their mannerisms, what's their actions? Are they having outbursts, their violence? How about their speech? Is it spontaneous? Is it slow or fast? Soft or loud? Can you understand them? Are they using the appropriate words? Do they have what? Oh, I love this fruit word salad where they're using confused or mixed words. I get word salad pretty easy. Um, are they using full words inappropriately or used together? Are they delusional? Are they depressed? Are they euphoric? Look at their mood. Are they anxious, angry, agitated? Do they have guilt? Do they have racing thoughts? Are they seeing sounds and hearing colors? Are there strange body sensations? Are they obsessive compulsive? Are they delusional? Are they suicidal? Are they unconnected? Are they disturbed or distorted? Once you have that complete mental status evaluation, then you should report their general appearance, their speech, their mood, and their area of thought or how they're thinking. It's tough sometimes to deal with mental health behavioral problems because we aren't trained. Our education as paramedics does not include a lot of this, and some of this is just OJT. You have to learn it on the job. You have to figure out where they're at. Um, and you've all seen these patients that have problems mentally. I, One lady pops to my mind. She was in her backyard of her house. She had on an aluminum foil hat. She had made a aluminum foil hat, and they had just put up a brand new microwave tower outside her house, and she just knew they were beaming microwaves into her house, and it was affecting her brain. and she had put an aluminum foil hat on. She'd gone into her backyard. Her family had found her, and she was there with an old hickory butcher knife, fixing to cut off her belly button, her navel, because the navel was talking to her. That was a bizarre mental health run I had. And you have to deal with those patients, and you have to be careful with them and make sure that you make contact with them, you engage them, and then they engage you, and then you try to reel them back into some frame of reality. uh, so it's tough to do. It's not easy, and sometimes, rarely, I would say, I don't think there's a great number of this, but we get into physical restraints on these patients. Verbal restraints is the first thing we want to try. But there is a thing out there called non physical crisis intervention that teaches you how to deal with these patients. And if you've never taken it, it would be a good one. What do y'all give me y'all's input on mental health?
I know a lot of times we tend to kind of blow mental health off. It's got a really bad stigma, and it's something that's even growing in EMS that is becoming more prevalent with PTSD for people in public service. Um, it's not a joke anymore, but it still gets laughed off a lot.
Mental health?
Yes,
Okay.
you see a lot of people, and I've done it in the past myself. We get called for suicidal ideations, and it's usually we just say it's somebody that's crying out for attention.
Right.
And that's not always the case.
Not always the case. You're right. And
It's something that
we're going to get into
something I've
suicides
started taking.
later on in this. Go ahead.
Something that I've started taking a lot more serious and having a lot more compassion for people who call for psychiatric issues, because obviously it's not what we see, it's how they feel. And sometimes we have to go by what they say, how they feel. Sometimes what they say, how they feel is really just a cry for attention. But I've seen it where it can get really scary for them and for the people that are trying to help them.
Sure.
Very nicely said, Greg.
And family members especially. Okay. We attempt to de-escalate the problem is our goal. We get there, the person is acting out, they're throwing punches, they're knocking holes in walls. You know, the lady with the butcher knife, was the scene safe? Well, no, it wasn't safe. But I was able to approach her, and she was on one side of a fence and I was on the other side. So I did have some element of safety there by being distanced from her. Um, that's the key thing we've got to remember this. Make sure that we got to provide our safety. Never let that patient that is acting out get between you and the egress, you and the way out. Make sure that uh, you know, if you see a weapon and you can't isolate and get farther enough away, then you probably need to leave the scene. Law enforcement, a lot of times on these scenes, is not the way to go, because law enforcement means that's going to escalate the situation in some cases. If you've got really cool law enforcement that will work with you, that will understand the situation and work the problem, they can be extremely helpful. But if they're there just to incarcerate, to hold, to restrain the patient, patient's not going to put up with that. Now, if you get there and there's weapons involved, uh, it says here to remove yourself, leave the scene. That may not be the best thing. Uh, Now, if they had guns, and I always followed the rule of gun. Greg, you ever heard of the rule of gun?
Always have a bigger gun than the person holding one.
No, if they've got a
Oh,
gun, ever who holds the gun makes the rules. So if they've got a gun, they're making the rules. They tell me to leave, I'm leaving. If they tell me to stay, I'm going to stay. And if I've got up in there and they've got a weapon like a gun, then I have gotten myself too deep into the situation and have become part of the problem and not the solution. So make sure, number one, you stay safe because uh, psychiatric emergencies, suicidal idolations, if they're suicidal, they can also be homicidal. So when we get in there, we need to be thinking, okay, how do I get myself out of here? How do I extricate myself from this situation? Um, if they are agreeable for you doing assessments on them, if they're agreeable you doing certain treatments on them, then you can get an IV established, and then maybe you can get a pharmacological restraint into them. Um, you know, that may be one of the ways that we can do that. But if you're going to try to overpower them with physical force, yes, Jamie, you're going to grab a hold of them and wrestle them to the ground. You better have enough people to do so. Anybody remember the minimum number of people required to get a mental patient to the ground?
isn't it 5 or 6?
Greg, you're right. It's five. One for the head, one for each arm, one for each leg, and you got to be coordinated. So you're going to have to talk to each other about who's grabbing what. Because if you all grab the left arm of this patient, that leaves two legs and another arm that they're going to fight back, and that would not be a good thing. So, coordinate it, make sure somebody gets a hold of the head to help it to the ground, the arms and the legs to get them down, and remember, we are there to physically restrain them for therapeutic reasons. The therapeutic reasons is we can't get ALS pharmacology in there. We've tried to verbally de escalate it. The physical restraint is the last gasp effort we have to do. So just remember that as we go through this. Um, you got to communicate your signals and cues. You got to be quick when you grab them. And you need to talk to the patient continually while you're physically restraining them. Because as you talk to them, it doesn't let them get into that part where they get to stressing out in their mind and they can slip into some other things. Um, you need to document your restraints. Those that are in law enforcement custody, they may have already cuffed and stuffed them. There may be others that may be. Excuse me just a minute. I have an alarm going off here. Good golly. Um, so, you know, if they're already in cuffs, you may need to leave them in cuffs. I don't remove restraints in the outer hospital setting because once you get them out of a restraint, then they may effectively try to escape, elude you. If they elude and they run off into the national forest, that's one thing. If they elude you while you're going down the road at 70 miles an hour, that's something totally different. And you go, nobody would ever jump from a moving ambulance. Yes, they will, and yes, they have, and yes, they will again.
Heck, yeah, they will. I had one try that when I was working for Pafford.
Yep. Were they successful?
Nope. My partner stopped him, grabbed him, and we stopped on the side of the road, called law enforcement, and she was taken with them.
Yeah. Um, Unfortunately, there was an ambulance service up in eastern Arkansas that was down around Searcy, and their mental health suicidal idolation patient got out of her restraints, opened the back doors, bailed out onto the interstate, and was summarily run over by somebody following the ambulance. Not a good scene, um, and it was kind of tough. Make sure that you can continue to restrain them and that you have adequate personnel and equipment to keep them down there. The key thing to remember, the key thing to remember here in this step 13 is the principle of restraint motion. We need to understand normal range of motion. You can lift quite a bit with your forearms going up this way, but you can't lift near as much if you turn your arms over. We need to understand the muscle groups. We need to understand uh, it's easier to abduct than adduct. So that's one of the couple of the key things to remember. We need to remember that the thumb is the weakest part of the grip of the hand. That's why when we do a power grip, we put our fingers underneath the bar instead of lifting with our thumbs underneath the bar. Um, and there are things in that non-physical crisis intervention that is out there. Let me see if I can give me just a second here. See, I told y'all I wasn't crazy. Right there it is. It's done by crisis prevention. You'll see in the screen, non-violent crisis intervention. It's a way to be used to you know keep you protected. Um, it's the NCI training network. Pretty good class if you happen to get to see one of those out there. Non-physical crisis intervention (CPI). Yep, it's a good class. So, and you can even learn more. I do believe they have some online classes there for healthcare professionals to make it safer for you, because violence in healthcare is pervasive and it's unacceptable. I agree with that, and it actually teaches you how to stay out of the problem. It was a very good class. I enjoyed it immensely, um, and would recommend that class to all. Okay, so some considerations we need to think about. I was trying to figure out where I was at. What about pregnant patients? How about restraining pregnant patients?
Only as a last resort.
And when we restrain pregnant patients, we need to remember if we put them on their back when they're the final trimester,
It actually puts them in danger of hypotension. So you might consider putting them on their left side.
right? Or putting a pillow underneath their left hip. That works too. What about pediatric patients? What do we have to worry about pediatric patients? Amanda, are you there still? I haven't heard from you in a while.
Yes, I'm still here.
Okay. What about pediatric patients when we restrain them?
They're slippery little suckers is what they are.
Yeah, they are. What about their physical attributes to them being restrained to the flat of their back?
You can cut out their airway because their heads are usually bigger than their bodies.
Right. So if we're going to restrain them, we should make sure we.
Put something under the back. Sit up.
Yeah. Yeah. Right, Amanda. Good. Pad behind their back, get their shoulders elevated, put a towel underneath there. Greg, did you have something to add?
I mean, sometimes you can restrain them while they're sitting up too. They don't always have to be laying flat. So I mean,
Little
that's
tougher to do, but yes, you can restrain them in a sitting position.
So you're saying I got to get rid of the duct tape out of my jump bag?
Yeah, don't duct tape, Cody. Sorry, sir.
Curlex works better than duct tape anyway.
Since you're here, yeah, and Curlex does not cause bruising and doesn't tear the skin. So we use soft restraints. How about them geriatric patients? Y'all all had them that want to pick you, pinch you, pet you, smack you. You want to restrain them. What kind of considerations come into play with them?
You have to worry about skin breakdown with them,
True.
especially if you're looking at a long distance transport and you're having to use restraints.
Yes.
I mean, you're gonna have to reposition the patient throughout the transport, just because 15 minutes you begin to have skin breakdown. Also, they're going to have thinner skin, so restraints have a tendency to cause skin tears,
Yes.
um, and they're prone to, with as you get older, you're prone to have more medical problems. So restraint, again, it's a stressor. You're going to cause an increase in blood pressure and heart rate, which can lead to other medical problems.
Sure. How about curvatures of the spine, bone densities? What does that got to do with the geriatric patient?
Your bones are more fragile. Your spine is going to curve naturally as it gets older. So again, laying somebody flat is going to be difficult, next to impossible, and if you do, can cause lots of pain.
Yeah, it's going to require some padding in there for these folks. Anybody else got any more considerations on pregnant, pediatric, or geriatric patients? Not hitting any, then we're going to go on to uh, environmental restraint. This is the one that I prefer using because this is the one that is less invasive. It is basically stabilize the environment, calm the patient, develop that rapport with your patient, that therapeutic communication. You may have a separation stimulus. If you've got uh, children fighting with their parents, you might separate that stimulus out. If you've got somebody fighting with law enforcement, you might, in a nice way, separate law enforcement out for a little bit. Try to de escalate, try to calm the event. You should be stepping in there going, okay, 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 everybody take a deep breath. Let's relax for a minute. Let's see where we're at, what's going on, because we got to figure it out. Uh, that is easier said than done in a lot of cases. Jamie, what is your best way to do environmental restraint? Surely by now you've had a few years under your belt. You have developed an environmental restraint for patients.
Absolutely. And I mean, for as, oh, maybe gruff or whatever, is I'm usually very direct and to the point. Um, as a female, I can really soften my voice and come across very sweet, especially, when it's a male, that can sometimes, well, back in the day, it used to make a big difference because guys didn't want to hit a girl. That's not so much the case anymore. But I mean, usually I'm able to, sweeten my voice and things like that. I'm not really huge. I'm a short girl, so I don't seem to be as big of a threat. So a lot of times those kinds of things will calm a situation.
True.
And and that's the easiest thing, and usually my first go to, of course, when I arrive on scene.
Well, absolutely. And when we get on scene, we have to step up and go, "Hey, we're here to help. We're not here to cause anybody any pain. We're not here to choose sides. We're here to help you get through your situation. That's what we're here for." And I walked into one house, a mental health patient, and she had suicidal ideations. And I walked through the door and she hollered, "Hello, Uncle Bill. Boy, it's good to see you. How you doing?" Did I tell her that I was not her Uncle Bill? No.
Heck no.
I used that tool to the nth degree to get her to calm down, to get her to go to the hospital to seek help. And we were almost to the hospital when she looked up and she said, "You're not my Uncle Bill, are you?" And I went, "No, I'm not." She said, "Well, that's all right. You look like him, and I'm going to do what you say because I like him and I like you." and that's a rapport. That is a therapeutic communication. If it all now, how it happened, I don't know, but she had it, and I used it, and we got her to the hospital and got her some help. The environmental is the best way to go. Now, once we go through and exhaust all our environmental restraint possibilities, then we've got to go into chemical restraint. And what are some indications? What's our protocol say about chemical restraint? What have we got to look for before we can step into that direction? Anybody?
Well, I mean, we need to look at what, now we're going with meds. So, what kind of allergies? We've got to get our sample history. We've got to get information on board so that we've got a baseline before administering anything, because not everything is good for everybody. Maybe
And
look at their med list and what they normally take. If they normally have Ativan or something similar, maybe it's better for us to go with Ativan because that's something that they normally take because it works for them.
yes, and if they are a threat to themselves or others, that moves them on up that ladder, brings them up to a higher level of quality of chemical restraint. If they are fighting, if they are threatening to others, then yep, that's a chemical restraint, definitely, and get it going. Um, Everybody agree with that one? And Jamie, you made some good points there too about what are they on, what's been working for them, and then we might give ketamine, benzodiazepines, or an antipsychotic. Uh, they may be the medications that we use to do that. Now we got to titrate it.
Right. And back with the environmental restraint, sorry to go backwards, but
It's all right.
sometimes if you're trying to de-escalate and go in with the non-threatening persona and everything else, that works for some people. Some people you got to switch it up and say, hey, look, this is what we're going to do. You got to take charge. They look for somebody to take charge and tell them what to do, and sometimes that does work,
And
but,
sometimes
but not
they
but not from a law enforcement perspective, but from a medical perspective. Sometimes they're more willing to listen to something. I may just repeat something that law enforcement has just said, but they've had bad experiences with law enforcement in the past, and no matter what they say or how they say it, it's not going to work.
it's true, very true. And sometimes if we go in and we try to uh, tell them how it's going to be, they balk up. They're going to, you ain't going to tell me what to do. Now, if you give them a choice, and that's one of the CPI training points was you make sure you give them a yes, yes. Now, we're going to the hospital and you can go by stretcher or you can walk to the truck. It's a yes, yes, because we're ultimately going where? To the hospital. We give them a choice
Right.
of how they go as long as they what? Go. And that's part of it.
Right.
Now, Greg, we don't want to snow them, do we? We don't want to just wipe out everything.
No, you want to sedate to the point that they calm down, and no further than that. You still want to be able to have be able to assess mental
Communicate. Yep.
communicate.
Yep.
Um, so I mean, you might not hit them with the full 4 milligrams per kilogram IM of the ketamine because that will actually put them out,
Yeah.
or most people, even though that's what our protocol says to use.
But
But
titrating to effect, if we talk to medical control, may be the best way to go.
exactly.
Yeah.
Um, but I mean, if you get going back, if you can gain any kind of a rapport, if you can get some kind of in with that patient, um, 9 times out of 10, if you can just get them to talk back to you, it will de-escalate that situation, more so than having to use restraints or medications. There are the cases that you don't have to, that it doesn't work though, and it can get ugly.
It can. And it can escalate quickly.
And here's another case where distraction can work.
Absolutely.
Where if you see something in the house that they're a collector, or there's some, distraction tactics can also work to de-escalate something.
Y'all seeing the screen?
Obviously, that depends on the situation.
Yeah. Y'all seeing the screen here?
Yeah.
Y'all recognize what this is?
Our protocol?
Yes. And I'm going down here. We're just going to look at the pain management protocols for a minute. There you go. Pain, adult protocol, ALS, BLS, patient refusing care. Is that
this is our psych? Is this our psych? This is our psych protocol, isn't it?
Well, wait a minute. Let me go back to the beginning. That's page 11. I'm going to go page 1 again. There we go. And it says right here, this is where I was at, pain management and standing orders, right?
Okay, I thought we'd moved on to.
Not yet. Oh yeah, pain management. I'm sorry. This is pain management. We're going to get to the psych here in just a minute. And 4 milligrams of Zofran. Yeah.
Casey, I don't see it. All I see is the
excuse me.
What you had originally.
I'm sorry. Let me stop share and share again. Thank you for pointing that out. There we go. How's that? That's the pain management.
Yep, there we go. I got it.
And you're right. 4 milligrams per kilogram on the ketamine. Might not need to do all that. Let me go back now, Jamie, to the other one that we were talking about, that refusing care. And I was looking for the chemical restraint. Do we have one on chemical restraint? Violent, there it is. Violent patient chemical restraint. There we go. This is right out of y'all's protocol, our protocol. Determine if subject is actually a violent, combative person. That would be good. Diabetic, hypoxic, stroke, overdose can be treated by EMS. Patient with no medical problems should be taken by law enforcement. Seen safe. If not, retreat and get law enforcement. That's always a good thing. Patient is able to be restrained by EMS, law enforcement for a reasonable period of time. Supportive care, yes. Vascular access, safe to do so. Is the patient a threat to self or others? Then go to the appropriate protocol. Somebody writing on my screen? There we go. Versed, 2.5 to 5 milligrams IM, IV, intranasal, up to 100, 10 milligrams, excuse me. And then we're going to talk about agitated delirium. That's ketamine, 1 milligram, up to 4. Ativan is there too.
Sorry, Casey, that was me.
Oh, that's all right. Go ahead and mark on it, especially if you got something you want to say. Valium, 5 to 10 milligrams. So we've got several things we can do for the psychiatric violent patient chemical sedation. So you've got a pretty wide swath of meds to use. So if you don't think Versed will work, then you can go with Ativan, Valium, and with agitated delirium, we're going to get into that, ketamine for sure for those people. Sedation should be only used to assist in controlling the patient, not to render them what? Not to render them
unconscious.
Unconscious. Thank you. Intranasal should be at a higher concentration, 1 milliliter per each nares. IV access should be obtained prior to chemical sedation, if possible, and use end-tidal and CO2 monitor on any sedated patients. So if you do sedate them, there you go. So what medications may we use according to our protocol for chemical sedation? Versed, ketamine, Ativan, and Valium, benzodiazepine. Comments, questions? Going out of this and getting into something else. Oop. Neil. All right. So that brings us down to agitated delirium or excited delirium. I've heard this talked about a couple of times. Tell me what you know about this.
It's usually something you'll see with somebody, certain types of psychiatric disorders, bipolar is one of them, that they'll get into a state where absolutely nothing you can say, do, is going, and they become either increasingly violent or towards themselves or people around them or their environment. It has a tendency to turn into a very dangerous situation for all parties involved, and it's probably something that you don't see a whole lot of, because as long as people stay on their medications, but it is something that you will see occasionally.
Okay.
Yeah,
Usually,
and from
go
what
ahead.
I've seen, it's pretty scary. I'm sorry, it could be really scary, and can also be drug induced.
Yep. Um, these people, when they are restrained and they have excited delirium, they can cause widespread chemical changes in their bodies to the point where they go into cardiac arrest. I am kind of interested, and certainly uh, sometimes with law enforcement restraining people, they can go into excited delirium, and law enforcement does not recognize it, and then they go into cardiac arrest, which can lead to death while in custody of a patient. Yes, they may be kneeling on their back. Yes, they may be kneeling on their neck. Yes, they may be kneeling in other places. But especially in the presence of certain opioids in the body, they can have this excited delirium. Am I saying is that an excuse for law enforcement to do what they do? And the answer to that is no. Um, but it is a possibility. And poot, sorry, I was looking for this white paper and it is not going to give me it. It's just going to be that way. Okay, hang on a minute. I'm going to go back to that. I got to, when it kicks me out, I got to go all the way around to get back in. Excuse me for doing that. All right, so let's see about this one. Opening a new window. There you go. So, y'all not seeing my screen, are you? Oh,
Nope, not now.
okay, you're going to. Here we go. And this is a white paper on excited delirium, and it is out there with the NCBI, the National Coalition for Behavioral Interventionists. Um, this is excited delirium study, and this one we came out in 2011, so it's about 10 years old. And it says, and this is a good definition of it: excited delirium or agitated delirium is characterized by agitation, aggression, acute distress, sudden death, often in pre hospital settings. It's associated with the use of drugs and altering dopamine processes. What is one of the drugs that wipes out dopamine?
Narcan.
Do what? Say again. Meth. Meth wipes out dopamine. So anything that messes with dopamine increases the chance of these patients having excited delirium. and leading to death while in custody of law enforcement. All right, especially patient dies from cardiac arrest, and which is from a hypoxemia, which can be debated. Unfortunately, inadequate treatment plans have yet to be established, due in part to these patients dying before they arrive at the hospital. So, EXD, uh, if we don't have a treatment plan, we're kind of in some deep, uncharted waters, right? Talk to
Right.
me, children of the EMS web. Okay, so here's their conclusion, and I kind of like this. This inadequate treatment plan is yet to be established uh, through rapid sedation, uh, external cooling, IV fluids, monitoring, and treatment of potential medical complications are critical to decrease morbidity and mortality. So, if we get there and we think it's excited delirium, one of the first things we need to do is rapidly sedate them, externally cool them with IV fluids, monitor and treatment of potential medical complications. Uh, Benzodiazepines and ketamine are among the potent sedative agents that have been proposed to stabilize EXD victims. Uh, while there is much to be discovered about the pathophysiology and treatments, it is hoped that this extensive review will provide both police and medical personnel with the information necessary to recognize and appropriately treat, you know, excited delirium. And I don't know if there's anything any newer on excited delirium. Anybody got anything out there newer than that? And I don't mean a Wikipedia study.
Casey, I'll be just a minute. I had a patient.
I'm sorry, Amanda, I didn't hear that. I tried to hear you, but I didn't hear that. What'd you say?
I'll be just a moment. I have my screen on, but I have a patient.
Okay, go ahead. Okay. Uh, Here's a 19 study. Let's look at that one. And this is excited delirium in the emergency department. This person here looks like he's in excited delirium. They give you a case. 25-year-old man uh, presents to the ED brought in by EMS with altered mental status. Yeah, that altered mental status is just like uh, domestic violence for cops. You just can't know. Prior to the arrival, the paramedic provided a radio report stating the patient was found agitated, behaving aggressively, then climbed on the hood of an ambulance. Yeah, I think if he climbs on the hood of the ambulance, that may be a little bit outside of normal. He was noted to be extremely strong. Difficult to restrain. Yep, and that just added to that ED. Paramedics administered 5 milligrams of midazolam intravenously and was able to physically restrain him, but upon arrival, he remains extremely agitated, yelling and slamming himself against the stretcher and sidebars. He does not answer any questions, and speech is non sequitur. On exam, the patient has marked tremulous, hot to the touch, mild clinical jerks, bruxism, excessive superficial abrasions are noted about his abdomen, thorax, and extremities. He's too agitated to obtain vitals. What are your next steps? Wow. Does not sound like a good time in the ED. Didn't sound like a good time on the ambulance either. This is a good set. What would you think you'd want to do right off the bat there, Jamie? What is the paper we read a while ago said there's 3 things we can rapidly do for these folks. What are they? One of them has already been done. The midazolam has what? Sedated him.
Cool them off.
Well,
Cool him off. Yeah. Cool him off is one thing we can do. Go ahead, Jamie.
well, shoot, I don't know. You just threw me for a loop now.
Well, cool him
You
off
say
is
my, you
fine.
say my, you say my name, and my brain goes wonky.
Sorry. Cool them off. Yeah, get an IV on them. Get some cool fluids in them. Sedate them. Keep them sedated, and treating the underlying causes. If they're in tachycardia, then we're going to deal with the tachycardia. We're going to have to deal with what's going on underneath all this stuff. High flow O2, yeah. Maintain maintain the capnography on them. You want their saturation to be up there. Temperature, yeah, that's true. So if we go down here and look at this old boy, they do some good for him, I imagine, because it's going to conclude the case here. Transferred to the ED stretcher, placed on a 4-point soft restraint, non-rebreather 100%, assist with hospital security. They give him 5 milligrams of ketamine, IM, significant reduction in agitation. Wow. If the paramedics on the truck had just given him ketamine, the patient was placed on entitled CO2 and was brought to the resuscitation bay to closely monitor. He was found to be tachycardic with a pulse of 150, hypertension at 150/94, and he was at 39.6 Celsius. Somebody's going to have to calculate that for me, but that seems warm.
Like 102 or 103.
Yeah, entitled CO2 is 38 millimeters of mercury by CO2. 12 aspirations for 20 minutes. Labs revealed no abnormalities. Cold packs were placed in his axilla and groin, at which time he went, whoo, and 2 liters of cooled lactated ringers was administered with improvement of temperature. Placed on the exam table, history concerning the excited delirium continued, and an unknown symptomatic agent with hallucinogenic qualities, and the patient was admitted to ICU step down for supportive care. Patient's agitated delirium resolved on hospital day 2. Day 2, he was in delirium for 2 days, and he was transported to an inpatient psychiatric for continual observation. He was discharged on day 4 with referral to psychiatric services and support for drug use. So he was on probably some kind of drug that reduced his dopamine, which reduced all that stuff. So here is the algorithm treatments for excited delirium. EMS indicates excited delirium. Verbally reassure the patient, establish a rapport, sedate the patient with ketamine, access for sedation, oxygenation. If there's hypothermia present, cool them down. If there's acidosis present, then you're going to give them lactated ringers, or even consider 1 to 2 milliequivalents of sodium bicarb. There's one of the reasons to carry the sodium bicarb. Okay, and that's a treatment that is from 2017. I think it's where this case study came from. 2017, I do believe. And this is a good quality. This is the EMRA, and that is uh, the emergency medical. Uh, yeah, looks like they are also with ASEP. So they are Emergency Medical Residents Association. Yeah, cool. All right, so let's get out of this. Let's get out of this. Let's get back to this. Whoop. Sharing screen stopped. It didn't go it went very fast, didn't it? All right, let's go here. Share. All right. So there are papers out there for excited delirium. We a lot of times see law enforcement, they restrain the patients at the scene, and they can get these patients really violent. There's a thing in the jail they use, which is called the comfort chair or the hug chair. But if y'all seen that chair they put the patients in and strap them down?
Yes, I have. They also put them in a vest.
Yeah,
They take all their clothes and put them in the vest,
It's called a pickle
padded
suit.
vest, basically.
pickle
Yeah.
suit because it's green.
Yeah.
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 Okay.
I've put my fair share of inmates in it when I worked at the jail.
Okay. Well, they also have a chair that they put them in. It's kind of
Yep.
reclining chair, and it straps them down, holds them in the extremities.
Yeah, you have to be you have to go through a special class to be certified to use it.
Right. But the thing they teach you in that class is to recognize excited delirium syndrome, EDS, because they can go into that from just that. Um, so we need to be aware when we get out there and the patient may have already gone into cardiac arrest when we arrive. The first things we need to do is cool them down and aggressively work on their cardiac arrest position. That patient that we just read the case study on, he was stayed in tachycardia for 2 days before he come out of that. So once they trigger one of these excited deliriums, it's just not going to rapidly. We're going to cool them down. We're going to make them feel better. We're going to give them some ketamine, and they're going to get better. No, they're going to say it's going to be a pretty good time for this to run its course to go through them. All right.
Right. Well, yeah, because there's no Narcan for meth and that kind of thing.
Yeah.
So,
And
I mean, there's no turning that around.
the problem goes back to dopamine in their brain. Not everybody that gets put in a chair and not everybody gets put in a pickle suit is going to have excited delirium, but it is something that jailers, law enforcement need to have in the back of their mind. They these patients, if they are getting into that excited delirium state, they're aggressively increasing. Maybe it might be time to step back a minute, get them up, use other restraints on them, other ways of taking care of them, and just be aware of that. And then maybe we can stay out of some of this uh, in custody deaths of patients. My 2 cents worth. Okay. My 2 cents worth. So, is this a problem? I don't know. I was looking earlier. I went out there and looked for data on excited delirium, and I'm not looking for treatment. I want to know excited delirium statistics. Statistics, yeah, right there. And I'm not looking for Wikipedia. Ah, looky here. Yeah, this is from the government here. This is the research 2016. Extreme end of yeah. I can't say that, so I wasn't going to say neuropsychiatric continuum. I was going to see what they said at the end of their conclusion, and that's some of the stuff that goes on inside them right there. Cocaine abuse. See how excited delirium here and cocaine abuse kind of goes hand in hand. There is their conclusions. And coupled with failed dopamine transport fluctuations. My goodness, meth can definitely give us problems, can it? Core body temperatures, chemical imbalance resulting in tachycardia, tachypnea, and hyperthermia. Hallmark. Hyperthermia is the hallmark of excited delirium and a harbinger of death in this syndromal disease. That doesn't sound too good, does it? All right, that was nearly not what I was looking for. Let me go back.
And that hyperthermia can be a reason why they are getting naked out on the street or in the Walmart.
Yep, might be. Okay. I think that was the one we read earlier. Yep, it is. And here we go. Yeah, here we go. This is somebody's perspective. Can you see the title?
Huh.
If
So are
excited,
these the same people that say that COVID is a
Probably
not
junk
not a real
science.
thing.
Yeah. And I don't know who O'Hare is and Altefa Sadadi, but and I don't know who. Oh, this is. Oh, I see. This is the Washington Post. Okay. So yeah.
So it must be true.
So yeah. Yeah. There. It is really. It is really something to it. I mean, and they got several comments, and I'm not going. I'm not going to get into that. But yeah. All right. Let's go back. So there is a problem with that. Hyperthermia is the biggest thing we got to worry about with these folks. Now, let's talk about suicides because that's where we're going to be headed here in just a minute. Let me see if it's got me some open in a new tab. Where's it at? Oh, CDC. Remember those people that deal with pandemics also deal with suicide. Did you know that suicide is a leading cause of death, traumatic death in Arkansas? Does that not surprise you a little bit?
That
That
does
does surprise me.
Yeah. So here
Although we do go out on a lot of them.
we do. Um, in fact, one suicide that just made national news was the guy in Georgia that was arrested for doing the Capitol thing up there, that riot at the Capitol. He actually went to his basement and suicided by shooting himself in the abdomen, and he died from it. Here's the risk factors. You got a family history of suicide, you're more likely to suicide. Family history or clinical child maltreatments. If you have a family history or child maltreatments, then yep, you may suicide. If you have attempted suicide before, guess what? You may suicide again. History of mental disorder, particularly clinical depression. I guess you could be depressed if you lived in Arkansas in certain places. Alcohol and substance abuse increase your chances of suiciding. Feeling hopelessness. If you don't feel there's any way out, then that may be something that you may do suicide. That may be in the guy down there in Georgia. He knew he was fixing to be cuffed and stuff and put to a federal penitentiary. That's hopelessness. So he took a weapon and shot himself in the abdomen. Impulsive or aggressive tendencies. Yep. Religious beliefs that believe suicide is a noble, resolution. Who was that? Those folks out there? Was it Arizona or California that waited for Hale-Bopp comet to come through and they drank the Kool-Aid and went off to ride the comet to Nirvana or someplace south of L.A. I'm not sure. Epidemics. There's local epidemics of suicide. Suicide pacts. If I suicide, are you going to suicide? And we all get together and say, if you go, I'm going to go. Isolation, being cut off from other people, barriers of accessing mental health treatments. That's a big one. Arkansas does not have a good mental health treatment network. It's getting better, but we got nothing there right now to support these people that feel that hopelessness. They feel that being cut off. There's loss, relationships, social work, financial. Those are losses that can be there. Physical illness, people that you know have physical illnesses that can lead to their brain thinking, and it's easily access to lethal methods. That's one of the things, and we're going to talk about two classes that's available to you to take online to teach you a little more about suicide. Notice I did not use the word commit suicide except one time and I slipped up. It is suiciding or suicided. There are two ways to say it. We don't use the word anymore, according to mental health people, this course that I took, excess. You don't say commit suicide because committing suicide means you are broken a law. And yes, it's a law that you cannot suicide, but you do not need to tell them they're going to commit suicide because it's an action. It's not an action, it's a choice. And that's what they're trying to get back to. We have access to lethal methods. I mean, anybody's got access to lethal methods. If you live in a big city, and you don't have a lot of weapons around you, like guns and knives and that sort of thing, you can go stand in the middle of a railroad track, go stand in the middle of the freeway. Somebody will run over you. That's a lethal method. You know, the worst suicide that I ever worked involved a 40-year-old female. She was depressed from having a baby, and she did not have any weapons. So she went out into her husband's workshop, took a circular saw, put it in a vise, pulled the safety back, locked the trigger on, and laid her neck into the blade.
Oh
That's
my God.
that's a lethal method. That's like cutting your head off,
That
you know. And
and sounds pretty committed.
who would have thought a 40-year-old woman, mother of three, would have done something like this? I mean, she waited and planned it. She put her kids on the bus to go to school. She called her best friend up and then went out and did this in the garage. And her best friend found her. And of course, it was too late, even though they called EMS. Um, Unwillingness to seek help, you know, because the stigma. Well, if I go to a mental health person, they're going to think I'm crazy. Well, here I am to tell you, folks, you are crazy. I mean, you don't have to go seek it, it's there. All right. So, those are some risk factors for people that suicide. And by the way, if you go over to, let me move to another screen here, if I can get to it. This is the CDC. We're going to go to healthyarkansas.gov, and y'all will find this one interesting. Arkansas Department of Health, and you can go up here and search suicide. Well, obviously I misspelled that. Here is the Arkansas Department of Health ground rounds, and they're actually doing a thing on suiciding. All right, and they do suicide. You go out here and I'm scrolling fast because I'm trying to get this done. Suicide prevention. Here we go. This is where it tells you that suicide is the number one illness, trauma in the state of Arkansas. And there are suicide prevention programs and education programs out there. Uh, this one, yeah, these are the ones I was talking about. There's one called Safe Talk, and it's by livingworks.net. This is a good one. This one right here is the one I strongly suggest anybody in EMS go to. And I'm going to have to go out and do Living Works here. Hang on a minute. And it's called, of all things, um, Living Works is, no, it's called Assist. It's called Assist. That's the name of the program. And it just sounds strange. But if I go to livingworks.net, there it is. And they have Safe Talk, which is an easy one, but the Assist is the big ones. They train over 200,000. They carry out 192 interventions, and they've trained 2 million people. So they're a pretty big thing. If you want to find a training near us, um, and we're going to look for a state, which would be where we at? Arkansas, right? Arkansas. Yeah. Search.
Now, come on, Casey, from a Razorback fan, are you really asking us that?
After they got beat by LSU last night, yeah, I know. Okay, here's one right. Here's one right here. It's an assist class on March the 11th. Okay, and it's in Bentonville, Arkansas. This is a 2-day class, and let me tell you something. You will come away with a different outlook, a different feeling about people that look at suiciding. It actually runs you through some practice things, some scenarios where you're either the person that is going to suicide or you're the intervention. It is a remarkable class. Markham does a great job over there. And also Schultz, Velvet Schultz is involved with this. She is an awesome teacher. The cost of this, oh, but can you see the screen? Can you see the cost right here? Can you
I
see?
cannot. It's kind of blurry on my end.
Oh, well, I wished I could blow it up for you. Let me see. Did that blow it up for you?
Oh wait, I got. Oh my gosh, is it free?
It is absolutely free. 2 days. The only thing it'll cost you is this one. Back up. Which one's this? Okay, I got to go back down. Hang on. I've got it too big for me. No, it's going that way, isn't it? Huh. Find a training. There it is. Assist. And that one is just, it's a 2 day. It's a 2 day. It's in Bentonville at Rogers. Okay, I click view. It's the 11th and 12th, so you're gonna have to spend the night over there. And it's 8:30 to 4:30, and it does take all day. And it's interesting the way they work at it because they come in and you interview the person and you find out if they have lethality. If they find you find out if they're having the means to do it, and it's sponsored by the Arkansas Department of Health. And I took the assist, and then I went back and took the safe talk, and safe talk gets you started on it, and the assist works you through it. And one of the things it does, if you've got somebody that's going to suicide and they plan on using pills as their medium, so you agree with them that let's take these pills and let's give them to a third party. So you have to ask that third party for the pills so you won't be able to use them to suicide. That's how this thing works. If they're going to use a gun, then you take the bullets out of the gun. You let them keep the gun, but you take their bullets out. So you take away that lethality. If they're going to use their car to suicide, then you take the keys to the car. Uh, it's a real good thing. It teaches you lots of stuff. It teaches you how uh, to 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 pick up on suicide, folks that are giving you waves of suicide, and how to do certain things with them. So it's a great class. I strongly urge you to take either the assist or the safe talk, but the assist works real good. Safe talk works if you're working with family members or fellow staff folks. Those all work great for those. All right. Questions, comments as we go forward here. I don't think we've got anything else to talk about there. History, we talked about that. These are the same um, 14 things that we carried out a while ago when we was talking about uh, the uh, the suicide for uh, the reasons for suicide. PTSD was another one there. Alcohol, drug abuse, loss of relationships, give away personal things. Who was that gave away a bunch of personal things and then blew himself up in Nashville? Yeah, he did that. Uh, Physical stress such as surgery, long periods of sleep deprivation, people that stay up and game and do stuff, they're tempting that. All right. I was going to go back to the Arkansas suicide page here. Here's a prevention toolkit. Here is the um, if you're in crisis now, here's a number to call. If you're a veteran, there's a number to call. In In 2018, 554 Arkansans died by suicide. That is just astounding. 554 people in the state of Arkansas killed themselves. Um, they have found it to be a major problem, and that's why they've come up and did some of the things they do here. Here's their toolkit. An after a suicide toolkit. That's a download. And then there is the model school policy for prevention. And wasn't there a school up in Missouri that was put doing things for suicide prevention or suicide awareness? And they had a bunch of billboards out there. Okay, so the CDC's out there. These groups here are there for you. So we need to be watching for those things. All right, I'm to the end of this section. Comments, questions? Check in with me. Let me know you're still there. Cody, you still there? I know you're here,
Yeah,
Jamie.
I'm still here.
Cody's still here. Greg, how about you?
Yeah, I'm still here. I was going to tell you, one
Please
of the
do.
deals with suicide. Recently, I had a call, and it actually broke my heart for this call. It was called to a school for a 16-year-old who wasn't talking about suicide, but actually attempted suicide in the bathroom at school. Um, Home life, especially with kids, is one of your big things that you have to look at. If they don't have a good home life, they're going to look for an out.
That goes back to the
Sometimes,
hopelessness.
yes. And this kid, I mean, he was a great kid. He just had he felt hopeless because mom jumped from boyfriend to boyfriend and put him in, situations that weren't safe for him. So he waited till class got started. Um, Told his friend that he was sitting next to in class, and says, "Yeah, it's not going to be long, and I'm going to be somewhere where I'm always going to be happy." And then looked at him and said, "Just remember, you were one of the ones that was always good to me, and I appreciate that." Got up, went to the bathroom, and tried hanging himself with his jacket in the stall. By the time he was found, he had almost succeeded. And one of the greatest things I got to do was I got to talk to this kid all the way to the hospital, and gives you a whole different outlook or different aspect when you're talking to them, and makes you think where you come from in your life versus where they're at in their life, and makes you wonder, what would have happened had you been in that same situation. Would you have gone a different way? Would you have had the same thoughts he did? And it was a very touching situation. And I ended up getting to speak to his mother, and I got to see why he felt like he did. He had a mother that didn't even pretend to care in that situation, and so it was a very heartbreaking situation. But it was also a very good learning situation for me on that, and it gave me like I said, it gave me a whole different aspect when you have the psychiatric behavioral calls and suicidal ideations. If they're having the thoughts, I mean, you can't tell somebody that they're not having thoughts.
Yeah. Was his lethality there? Did he have a lethal way to do it?
Oh, absolutely. I
Yeah,
mean,
and he had thought about this. He had a plan. Right?
and a very good plan according to the principal who found him. He was almost completely unconscious by the time he was found, and they broke into the stall. So it was a very, very tense situation, but also a very, very good situation on the school's part to see how
To record this one. And I tell you what,
So
Jamie, if
now
you'll
you
talk,
are.
Jerry,
No, you recorded earlier.
yeah, I did, but I didn't record this last little bit. Jamie, if you'll get in touch with me, I'll give you a reason how you can reasonably do it. It'll meet our
Okay.
criteria. Okay.
Okay.
So there you go. All right. So that's junctional tourniquets. Have you now? Did you know about junctional tourniquets before this, or is this a new idea for you guys?
It's new to me. I've never seen it before.
Yeah, it's
Yeah, this is new to me.
it's rather new, but it's a way to put on a tourniquet that shuts off at the inguinal area at the femoral artery or at the brachial artery underneath the arm. And the SAM will do the arm, the jet will not do the arm. So, if you're going to use axillary and femoral, I would suggest you to do the SAM. And SAM is owned by a paramedic like yourselves that got smart, entered into manufacturing, and yeah, and the trauma casualty care course that's put out by the National Association of EMTs both agree that any of these junctional tourniquets are good for you. I did not, and I meant to. Yeah, let me go back just a minute. Shopping. I'll give you an idea here in just a minute. The uh, the Croc is that ain't right. Yeah. Oh yeah, there it is. The Croc is $682.
Wow, are these one-time use or
Yes.
you may have? Okay, I was gonna say you may have gone over that and I missed it, but
No, no, no. The Jet is going to be 359, and well, I guess that Croc is reusable, uh, but the Sam is not. The Sam is only 299, and the Jet is 365, 259. So I guess the Sam would be the cheapest one of all of them.
that seems reasonable, I guess.
Yeah. So there you go. And you don't let, this is the reason you don't let just anybody buy. If y'all are looking at my video, my screen here, the Sam is 299, but here's a Rats rapid application tourniquet for 14.95, and they go, oh yeah, that'll be, it's just good. No,
Right.
Rats
No, not
is
so much.
just a tourniquet, whereas this other one is a junctional tourniquet. Yeah, so there you go.
And it seems like, with our location in the world, it would be beneficial to have. I mean, we're talking life or limb, so
Yeah, absolutely true. And it's up to you. It's up to each service what they want to use. All right.
right.
So there you go. Now the next part we're going to talk about is going to be hemostatic agents, and quick clot, those sort of things were out right during the height of the uh, Iraq War, and it was basically a powder that they sprinkle in, and that got good, and they had problems out there. And y'all have all seen the video of the pig that they cut the femoral artery and they pour in the quick clot and it stops the bleeding, and it's all miraculous and good and wonderful. But they found out
Have you
that
seen the new? Well, it's not new. Like the little mini tampons that they inject. They push a button and it injects it into the wound, and it just spreads and stops it.
okay, you got me going. What's it called?
I'm not
I don't
sure.
I don't think mini tampons is going to work.
Well, I mean, it's like I don't know because they come up with it after I got out of the military, so I never did get to see it except for on the
See,
internet.
see, that didn't work there, did it? Because many tampons took me to some interesting places here. So let's get out of this.
So Cody, is it like like the little mini thing that they would use for nosebleeds that maybe um soaked with or treated with an anti-clot agent?
Um, I'm not sure. I think I found it. It's a syringe loaded with little bitty. Um, here, I found. Let me send you the link, Casey.
That would be
And
good
you
because
just
I'm looking at something here that looks a lot like it.
you push it down. That's that. Well, see,
That's C-lock, right?
here's what I'm actually talking about. I just sent
All
it
right.
in.
Okay. Is it in the? It's in the.
It's in the chat. Yeah.
Okay. I'm gonna go to the chat and get it. I'm going to medicine 464. All right, let's see here. Oh, there it is. Oh wow, look at those big things. Let's watch this video if it's not too long.
FDA approves device that stops gunshot bleeding in 15 seconds. The United States Food and Drug Administration has approved the civilian use of this device that can be used to stop major hemorrhaging. The XStat Rapid Hemostasis System was approved for use by the military last year, but now the innovative wound dressing device can be used by the general public. XStat 30 is a syringe filled with tiny expandable sponges that work to fill a wound and stop hemorrhaging in 15 seconds. There are 92 sponges in each syringe, but the number of sponges needed to stop bleeding varies depending on the wound. 3 syringes can be used per patient. Using an XStat gives the patient 4 hours to seek professional medical attention. Sponges have radioplaque markers, so an X-ray can pick up any sponges to help in the process of extraction. According to the U.S. Army Institute of Surgical Research, 30 to 40% of civilian deaths by traumatic injury are the result of hemorrhaging. XStat is for areas of the body where it is difficult to use a tourniquet.
Hey, can we watch the poo chew train?
No, we're not going to watch some poochie. No. Nor are we going to watch this lady up here with the news and the funny. I don't know what that is, but yeah. Was that my poochie train or was that something else?
It was like a suggested video that popped up on top of that video.
Yeah, that is pretty interesting. What is that called again? Because I want to know the name of it. XStat.
Yeah, I can't remember the name of it. Like I said, the Army come out with it back in 2010 or 11.
Y'all hang on. We're working on it. Yeah, see that C-lock's come up again too. XStat has been approved by the Trauma Casualty Care Group. So there you go. Here's a different video. Would you like to see a different video?
Hey, I'm Ryan, and today I'm going to be talking about the XStat. The XStat's a T-C recommended device for controlling deep, narrow tract junctional wounds in the groin and the axilla that are not amenable to a tourniquet. So there are 2 different types of XStats, the XStat 30 and the XStat 12. One's for bigger wounds, one's for smaller wounds. The XStat is a temporary device for use up to 4 hours until surgical care is required. So a few things that you need to know about the XStat. It is not for use in the pleural cavity, the mediastinum, the thorax, the abdomen, the retroperitoneal space, the sacral space, tissues above the inguinal ligament, or tissues above the clavicle. Okay, so how the XStat works is the XStat 30. It's just a syringe, so all you're going to do is grab the plunger, pull back, set. Keep in mind that once it's locked, you cannot push the plunger back anymore. Insert the applicator into the wound as close to the bleeding source as possible. Once you meet resistance, simply push down on the plunger. If you meet more resistance, draw out slightly and depress the plunger. Do the same until the wound cavity is completely full. The XStat contains compressed mini sponges. Upon contact with blood, the mini sponges absorb blood and expand to 10 to 12 times their compressed volume within approximately 20 seconds. A radio-opaque marker is embedded into each of the mini sponges to make them detectable by X-ray. Use additional applicators if necessary to completely fill the wound with mini sponges. Then apply a pressure dressing. If the bleeding is not controlled, simply apply direct pressure. And remember to document XStat use and all patient care on a DD 1380.
Do y'all use the DD 1380?
No. What, Casey?
Do y'all use the DD 1380? No. Okay. All right. So, but we
did years ago.
Years ago, yeah. So there's XStat, and that puts the little sponges in there that takes care of it. The hemostatic dressing was in there, but now they have hemostatic impregnated gauze, which is like the Israeli dressing, and it works pretty nice. Here is an article on pre-hospital hemostatic dressings, and it basically is a surgical or a review of the different things. And if you want to know more about it, you go down here to the end of it and look at its I always like the conclusions. There's the conclusions here. This is 2013. My gosh, that's almost 20 years ago. They did have some ideal pre-hospital topical hemostatic dressings. They do stop. They're lightweight. They're easy to put on. They have a shelf life of 2 years. Quick clot and hemoclon should be considered current standards, and wound stat, combat gauze, and Celox may be more effective in hemostatic agents than hemoclon and quick clot. And these products are new devices they've developed and work well. So, yeah, that's it, Celox. And that was the other interesting one that we were seeing a while ago was the Celox. There we go, Celox. So, yeah. And these are granules. I guess these Celox granules actually spread apart. Look at there. That thing's only $27. Huh.
What a bargain.
Yeah, compared to some of the other things we've seen.
I will say those granules will burn like hell when you put it on a wound.
Oh, okay. Well, at least you can stay warm. I'm sorry.
Well, I'd say if it comes to a point of that type of application, that the burning sensation is going to be the least of your worries.
Yeah.
Right.
Okay. Let's watch a short video on this Celox A 120. It won't take but a second. We'll a minute and 20 seconds, and then we'll here it is. And this looks like a real patient.
Hemorrhage from narrow injuries such as bullet or stab wounds can be difficult to control with gauze or granule hemostats. Celox A enables you to target the source of the bleeding quickly and effectively. To prepare Celox A, remove the cap from the top of the tube. Insert the plunger and remove the end cap. Insert the applicator into the wound and push the plunger to dispense Celox.
And so it burns, right?
Withdraw the applicator, cover and compress for 3 minutes. Check that the bleeding has stopped. If bleeding continues, compress for a further 3 minutes. Once the wound is stable, bandage over the area to prepare for evacuation. Finally, attach the used packaging to the casualty's clothing for the medical facility staff to see.
Because they're going to get together and go, man, come here and look at this. You ain't never seen nothing like this before. All right.
I don't know
Now,
how.
that one at least looks like it bonds together. The other one that Cody was talking about with all the little tampon cushions. Yes, I mean I see how that works and everything. And of course, my first concern was, how in the world are you going to get all those out? So I mean, I like that they've got, they're visible on X-ray or whatever else. So that seems like it would be, an easier one to actually remove and debride. But this one, it kind of looks a little hinky.
That's what I was about to say is that the reason why they come out with that, because I've heard that the Celox, the powder, cakes together and they have to scrape it off the wound once they get to the hospital. A lot of doctors don't like that because that it like coagulates so bad they have to scrape it off to get access
and,
to.
I mean, I would imagine that could possibly cause, further damage that you're trying to avoid, or you've already got, quite a bit of trauma in that area before you start there. Huh. Interesting.
Yeah.
In case I ever get shot, don't use that one on me. Just use a regular tampon, I reckon.
That could work. Look at this one right here.
I mean, it even has a string. So
what you're about to see
is
an excerpt of testing performed by the United States military to simulate the most severe battlefield injury imaginable, the complete bisection of the femoral artery and vein. The objective was to identify the field treatment that provides soldiers the best chance for survival. The following procedure was performed to test and compare the efficacy of currently available battlefield-appropriate hemostatic agents. Using subjects weighing approximately 110 pounds each, the trauma doctor slices through the soft tissue and all muscles throughout the vital groin area down to the femoral artery and vein. The doctor now places his gloved hand over the wound to prevent the spurting of blood that occurs as he completely bisects the femoral artery and vein. The wound cavity is immediately flooded with blood. Suction is performed to measure the volume of blood lost as a hemorrhage is allowed to proceed uncontrolled to simulate the standard response time. If no action is taken, the subject will die due to exsanguation or bleed out, the leading cause of battlefield deaths. A single dose of QuikClot, 3.5 ounces, is dumped directly onto the bleeding wound, and pressure is applied using the standard military dressing. Hemostasis is achieved almost immediately after applying QuikClot to the trauma. After the gauze is removed from the wound, you can clearly see the QuikClot. The top layer is untouched by the bleeding that normally would have saturated the pressure bandage. You can see QuikClot is easily irrigated out of the wound, leaving behind a tenacious clot resulting from its rapid absorption of fluids. This allows the body's own natural clotting factors to become highly concentrated. The treatments tested included the standard military pressure dressing, Marine Polymer's RDH bandage, Metaphor's Traumadex, and Z-Medica's QuikClot. QuikClot was the only treatment that reduced blood loss and increased survivability better than the standard military bandage. In fact, QuikClot was the only treatment to achieve a 0 mortality rate, or 100% survivability.
Woo! There you go.
So it is easy to remove. I've always heard otherwise.
Yeah, according to them, it's easy to remove simply because you can wash it out. And you have to admit, that's pretty impressive that they are taking water and pouring over this to get this clot. By the way, that test subject, that 150-pound test subject they used there, he did have a first name. His first name was Barbecue.
Har har. What I would like to see is that, if there was some way to, because we're looking from the outside in. So of course, once all that is poured on that wound, we can't see anymore. So yeah, it's not coming out up to the surface and soaking, he mentioned that it wouldn't soak, it's not soaking through a pressure bandage like it would normally do. But that doesn't mean that blood is not going elsewhere within the tissues. You know what I mean? I would like to see if they were able to do that test with seeing where the blood goes when it's not coming out, and how long it actually takes for that to clot.
Well, apparently it clotted pretty quick because it reached a zero mortality of it. So yeah.
Yeah. But being the skeptic that I am, it's like, yeah, but if it takes 3 minutes for it to clot or whatever and do its thing, okay, so that means that wound is still bleeding for 3 minutes, and just because you're not seeing the blood on the outside doesn't mean that it's not still
going somewhere
elsewhere. Yes.
Yeah. Okay, let's talk about this next one, and this is going to be TXA, and I got a video here for you to watch. I think I have a video for you to watch. Back up. I thought you had a video. Yeah. I gotta find it. It's down here somewhere. Well, I guess not. There we go. We'll find some other here. Let me see. I'm in videos. There should be a video. That's a summary. Okay. Watch this
Hi,
video.
my
I'll
name
be
is
right
Patrick
back.
Kim. I'm a trauma surgeon and the Trauma Program Medical Director at Penn Medicine's Level 1 Trauma Center. Uncontrolled bleeding is the leading cause of preventable death in trauma patients. So I'd like to talk to you for a few minutes about tranexamic acid, TXA. TXA is a medication that helps us control bleeding after trauma. It works by stabilizing the blood as it tries to form a clot at the site of bleeding. It actually helps the clot from dissolving. TXA is a medication that's been around for decades. It's been used to treat bleeding in a wide variety of patients in the emergency department and the operating room, and it has a long track record of being safe and effective in these patients. More recently, it's been used to treat bleeding from trauma, and based on good medical studies of trauma patients around the world, including treatment of combat casualties, TXA is clearly saving lives. It has the greatest impact on survival in the patients who are bleeding the most. In one study, TXA improved survival by 14%, which is remarkable for any single medical treatment. TXA is an important part of our trauma center strategy to stop bleeding and save lives. Although it's not a replacement for blood transfusion or prompt surgery, it's an important addition to these treatments. TXA is a safe and effective adjunct to hemorrhage control in bleeding trauma patients, whether given pre-hospital or in the trauma bay. It's a potentially life-saving treatment and should be considered in your next bleeding patient. For more information on Penn Medicine's Level 1 Trauma Center, please visit our website.
TXA for hyperpigmentation.
Good grief. Well, going where the money is.
Yeah.
Yeah, that medication was originally created for women who had heavy flow periods. It was sold over the counter and originated, I believe, in Australia.
Wow, that's interesting.
Did we lose Casey?
I think we did. Maybe he's going pee.
Okay, she decided to take a nap.
Are y'all there?
We're
Yeah.
here. Are you okay?
Yeah, I had an urgency. You ever
See,
have?
told you.
Yeah, urgency. I had to run. That happens sometimes when you're that age, that delicate age. Y'all will get there one of these days if you have good, clean living. So, what did y'all decide about TXA?
I think it's a great use. It's a good medication. There's a lot of doctors like down at UAMS that have actually started complaining about the use of it to the point where some EMS services have actually pulled it off of their trucks.
What is their complaint about TXA?
I don't know if it has to do with once they get into surgery, but I know it's the reason that Baxter pulled their TXA off the truck.
Okay.
Well, I know that there was a because I remember seeing this when I went to a conference many moons ago, and I was really impressed by it then, and brought back some research to our higher ups, and then we ended up getting it on the truck. But there was a big issue with all we could do as EMS was give like an initial dose, and it had to be followed up in I don't know how many hours or whatever. I don't remember what it was, but so it was a kind of a matter of we were going to need to make sure that we transferred those patients to a hospital that could do the follow-up treatment with it. And so that was kind of an issue for a while. So I don't know if that may have something to do with it as well. But if a lot of them are having issues and not liking it, then that would be a problem if we were administering, the initial dose and it wasn't going to be able to get followed up.
Yeah, but I haven't heard of any problem with it. Wow. That's an 18. I'm trying to do a little research on it to see if I can see anything. Stat pearls here for TXA. There's one here called TXA, a life-saving drug that's too cheap to bother using.
Well, that's interesting.
Yeah. And I didn't know that. It was sold over the counter in Europe. So do you remember why they didn't want TXA used again?
No, but Greg had mentioned, I think you missed it at the conclusion of the video, Greg had mentioned that it was initially used in another country for women with excessive period flows.
Yeah, that's true.
Where was that, Greg?
I believe it was in Australia and in Europe as well.
If you go to drugs.com, it'll actually tell you about the use of TXA that way. Okay. All right. And I was going to look at that right quick, but I'm not going to now. So we're through with TXA and trauma. Amanda, we need you. You got anything for us? No, she went off again.
Okay, so let's see. Now we move to operations. Yay. Out of trauma into operations. That's always a good step in the right directions. And we're looking at risk populations. This one, when you hear at risk populations, it's not exactly what you think it is. When you think of at risk populations, what are you looking at?
The elderly.
Well, that's what you think, but this is the blue campaign. This is human trafficking awareness training, and there is
Oh, wow.
yeah, that's the at risk that they're talking about here. And we play a real vital role because we're out on the highways and byways at all hours of the day and night. And we will be one of the first hand people to see trafficking possibly taking place. Uh, there is one for truck drivers, law enforcement, and these are courses that you can take online. And this is combating human trafficking in tribal communities. There's one here on just trafficking vitals and why do we do it? Why do we watch? What do we look for? You know, so this is a big thing is dealing with human trafficking. All right. I'm not going to watch play any of these videos, but if you'll go out there to that blue campaign, it will give you some stuff. One of the trafficking programs that I had to deal with getting my CDL was that way. We're looking at human trafficking as one of our devices that we look at, and domestic violence is the other special
Huh.
risk needs that we deal with.
See, and for me, my first thought for at risk, other than elderly, would be like homeless population, people that don't eat well, that don't have health care, that you know, that's my first thought.
Well, if you look at it, we're out and about at all hours of the days and nights with our ambulances, and we will be called to respond to some of these people who are at risk, especially those that are being trafficked. And we may be seeing the first clues of it because if one of the girls or guys in the stable gets sick, that's an asset that they want taken care of, the traffickers. So they will call EMS and we will get there and we'll start interacting with the patient. And all of a sudden, the patient is not answering our questions. It is the person that is doing the human trafficking. Then we're going to see injuries at certain stages of healing. We will see um, things that just aren't right. The wrong type of clothes and the wrong type of weather. We may be called out to an area where, uh, you know, typically young women aren't found, like a truck stop area or a truck parking lot area alongside the road, maybe even out to the welcome centers. um, you're going to see these, and you'll see tattoos on these girls with crowns with numbers in them, and the crown means they're the part of the crown stable, and their number is their number that they're called when they're in their stable. So we see that stuff on human trafficking, and there are some ways out there that we're going to be able to pick up on things we that other people may not see, and we need to have a heightened awareness. We need to have a heightened sensibility to human trafficking, and be aware that it is going on, and we need to take part and far as in breaking that cycle. That's why some of the bathrooms that you see that are open like 24 hours a day, like the Casey's and that sort of things, they have a little a phone number in there where they can call 1-800. It's SOS is actually, when you look at it, 1-800 something 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 something, that gives them a call number. The other one is going to be domestic violence, and we see patients in their home. We see where and how they got this injury, and we need to learn how to watch for those and screen those. And there's training out there for that, for domestic violence here, and for also human trafficking. And this is both out there by the National Prevention for Domestic Violence for medical professionals. So we can see the laws, we can see what's out there, and this is the part. And you could take the 6 parts in a quiz, and it's put out there by the Attorney General. This is of the state of Florida, and you can actually get CEUs by taking this class. So it's pretty interesting. But that's what they're talking about here, because there is a wide range in development from neonatal to young adults, and these people are nonverbal to highly communicative, and their injuries and illnesses patterns change with development. You got the geriatrics, that's the older age that might be at risk, and they might be at risk from their own caregivers, because mama, if you don't do this, I'm not going to give you this. You're not going to watch TV, or there's going to be different ways for them to be at risk. Polypharmacy is very common in these patients, and there may be overdoses because they don't really know. They may have dementia and delirium, and a lot of it may be loss of independence, where they're not able to drive, they're not able to stay by themselves, and they may have to they may have reduced uptake in their bodies for certain medicines, and that may indicate that. So domestic violence is another place that we look at. We need to look at arms and neck and face and heads and backs and buttocks and breasts and abdominal increases during pregnancy and genitalia that may be damaged, and look for wounds in different types of hemorrhaging. There is that human trafficking, as we said, bruises, urinary difficulties, kidney infections are very common with traffickers being trafficked, chronic back, cardiovascular, respiratory, forced labor in unsafe conditions, poor eyesight, malnutrition, disoriented. They may have phobias. They may have panic attacks. They may actually cringe when they're around their caregiver. We need to try to assess them. We're going to find them to be unreliable historians. They're not going to know where they were at or what they were doing. Uh, Difficulty in relaying information like medical history, medications, or other therapies. Reliance on their caregivers. They're going to be very attached to their caregivers. Uh, you're going to be able to listen to the patient's verbal and nonverbal communication, watch the way they interact with their caregivers, and we're going to do supportive care. We're not going to give the caregivers any clue that we may think something is going on, but as soon as we get them out of the sight of the caregiver, yeah, then we're going to bring it to bear. We are mandatory reporters, so therefore if we see something, we must say something, and we got to document our findings, and we can't be bashful in reporting what we've seen, what we saw, what goes on. All right. Questions about special needs, at risk population, I should say. Jamie?
No, but I do want to say that where we're mandatory reporters, we need to make those phone calls ourselves. We cannot. I learned firsthand that you can't rely on giving that information when you turn your patient over in your report and expect the nurse or whatever may say, okay, yeah, we'll give a call. You can't expect and count on that call to be made, even though they're mandatory reporters as well. We can't pass it off. We actually have to make that phone call ourselves.
Yep. Drop the
to
dime.
make sure that that's closed.
Yes, I agree. We need to make that phone call ourselves.
Take the time, drop the dime. It's just going to keep you out of trouble, because if the nurse doesn't report it and something happens and they come back and they start gathering people for prosecution because you didn't call it in and you thought you turned it over to somebody else, that's not the way the law states it. It states you must report it.
Yeah.
Okay. Cody, Greg?
No, I don't have anything.
I'm good.
Okay, good. Moving on. Ambulance safety. Let's see, is that the next one down here? It is. It is. It is. That's good. So we have had a push for safe ambulances, and that is something that is extremely good news for us. NHTSA has put it out there, and that comes from the website ems.gov. Gov. That is the clearinghouse for EMS in America. This is their different uh, projects they're working on. There's an opioid crisis, there's a nomenclature, there's education standards, CPR, Agenda 2050. You want to know what EMS will look like in 2050? Right there it is. Stop the Bleed and Nemesis. This is the education, and here's the safety. And they want safety in the workforce, and they're working for ambulance safety. And they work with different people and agencies that help do that. And uh, safe on the road. How can we be safe on the road? Let's take a look and see what this is. This is one we're supposed
Welcome,
to watch.
everyone, to today's edition of EMS Focus, a collaborative federal webinar series. My name is Max Severide, and I'm an emergency medical services specialist with the National Highway Traffic Safety Administration's Office of EMS. Together with our federal partners, NHTSA's Office of EMS is focused on advancing a national vision for EMS. The projects we undertake and the resulting resources for the community help with systems improvement, measuring the health of EMS systems in the United States. We estimate that 4,500 crashes involving ambulances occur annually, with about a third of those resulting in injuries, including 33 deaths. Unfortunately, most of the EMS clinicians who were killed or injured in the crashes we investigated were not wearing seatbelts. In fact, 84% of those riding in the patient compartment were not restrained. Now, this data is a few years old, and we're working on updating it right now. Thinking about your own practices in an ambulance and those of your colleagues, where do you think that number is now? Are we still taking unnecessary risks? Do you ask your driver to stop so you can treat your patient unbelted and then buckle back up? Next slide. As for patients, most who were in ambulances at the time of serious crashes were not secured with both lap and shoulder restraints, despite evidence showing that both are necessary to keep patients safe. We'll be talking about several issues today, but don't forget that sometimes the most obvious and easiest solution is also the most effective one. In this era of COVID-19, when we tackle issues such as shortages of masks and gloves, don't forget that one of your most important pieces of personal protective equipment is the nylon strap and buckle that is always available to use. Wear your seatbelts and properly secure your patients. Your patients are counting on you to keep them safe. Next slide.
So this is a webinar series. It's over an hour long, and we won't go into that. There are some different things out there that you can look at. This is a safety video that's out there about improving safety. Oh yeah, this right here.
Would you like to get a new metal roof installed for $89?
No, I would not.
We're offering huge savings.
I can't afford the other parts, so there you go. This is ambulance crashes.
In the early 2000s, NIOSH began investigating opportunities to improve occupant and worker safety when in the patient compartment of a moving ambulance by crash testing a variety of ambulances. Crash testing ambulances allows engineers to better understand how the structure reacts during front, side, and rear crash events. This module covers the value of crash testing in the design process and explains the underlying characteristics and testing methods used to evaluate an ambulance in front, side, and rear crash testing. You'll also learn how data collected from these tests serves as the basis for developing safety innovation.
For example, performing a vehicle frontal collision, we perform that test with the vehicle traveling 30 miles per hour into a concrete wall.
During a crash, some of the energy is consumed as the front of the vehicle is crushed.
Yep, 30 miles an hour into a concrete wall. Wasn't that something? I'm looking for the next part here. I was looking for something that just showed crashes. Yeah. if you look at that ambulance right there, whoop, back up. That's pretty significant. Look at the cockpit of that truck right there. That's amazing. So NHTSA is working on some different types of crashes and things that occur. Um, that's Braun. That's Cap. This is CAPC here. This is pretty good here. This is one we looked at. They actually put people in the back of it.
Fire the pops up. 10-4. 3, 2, 1.
This test was particularly significant. We've had a number of vehicle manufacturers ask about the ability to do real-world rollover testing and understand better what happens to the vehicle integrity in rollover events, as well as what's happening to occupants in rollovers. And so this gave us an opportunity to demonstrate our ability to answer some of those questions. We wanted to perform a test that would continue to roll not 90, but 180, 360, and maybe beyond. That introduced some challenges. We had to design some unique equipment that would allow us to put a vehicle on a cart sideways and stop it in a few inches. We put concrete pads to protect the track, but also we designed and built those concrete pads so that they had a very rough surface on them so that they would help promote the vehicle to roll. We also wanted the vehicle to slide easily off of the cart, and so we had ramps that are on the passenger wheels, both front and back wheels, that were rising about 14 inches at a 25-degree angle so that the vehicle would slide, helping to induce the roll. Our engineers designed a Hexcel stopping pad, which is aluminum honeycomb structure. So when we impacted it, it crushed from about 8 inches thick down to about 4 inches thick in a very quick moment.
That looks like a fun time.
It's a lot of preparation for a pretty quick test. It takes about 5 seconds to get down the track, to get from 0 to 25 miles an hour and hit the barrier. And once it hit that barrier, it tripped and rolled in about 4 seconds, and it was all over. So the whole event was about 10 seconds in total length. So we were able to accomplish the purpose that we set out, which is to get a vehicle to roll on our test track in a repeatable test environment. It takes a lot of clever minds, a lot of creative thinking to accomplish that. We were very pleased at the outcome. It was a raging success.
So,
would you like to get a new metal roof installed for?
I said no. We got to get off of that. There's lots of videos out there with test crashes. There's some out there of exposure and ground ambulance design. And some of that on ground ambulance design has actually come about from how they're going to change and make ambulances safer. And that's where we go to this safeambulance.org, ground ambulance safety resource, and they're actually how you can do certain things. This is their crash testing. This is put out by the SESMO, Arkansas State Specific. That's us. Regulates, but does not use any national standards. There's no regulations in Colorado or Wyoming, but they've got recreational marijuana out there, so I guess that's all right too. Also in New Hampshire, they have no regulations. Now, Missouri does require specifications, so there are some things out there, but they are constantly trying to develop safe ways for us to ride in the back of the truck. So how we can help ourselves and be EMS safety. And this is
They don't have regulations in Colorado.
No.
So it's crazy because if you get caught, it's certain, like Lake City's south of Gunnison. If you get caught driving past certain points on a side-by-side, it's a $5,000 fine.
Huh.
Because it is a danger.
Really? Huh.
Yep, and I didn't know that till after I drove past that point.
Ooh.
I didn't get a ticket. They told me drive on the highways because this isn't far from Silverton. You could drive on the highways, but you have to stay, like even in Silverton, you have to stay on a certain route. They got signs. And if you get caught out of that route, $5,000 fine. Somebody told me, oh, yeah, you can't do that. I'm like, thank God I didn't get caught. So if they can enforce that for safety reasons, why can't they have ambulance regulations on safe? It makes no sense.
Does not make any sense. By the way, safeambulances.org actually has recalls on ambulances here, make and model and years of certain ambulances. So that's kind of interesting. They have a video series out here where ambulance crashes and all the stuff they do. And some of these are pretty interesting when you watch some of these crashes, especially the cot crashes. And this is the one that's out of, I'm going to click on it just a minute. We're talking about safety, so we might as well look. This one here
began work on new testing requirements to improve the crashworthiness of the patient cot, also known as the litter or gurney. Through the partnership, cot manufacturers have designed and tested a range of products to meet these new testing requirements. These new testing requirements are now published as SAE J3027. This module will cover cot developments in mounting systems, strength testing, and patient restraint, in addition to providing information on manual and powered cot options.
We're not going to go there, but there's stuff out there that you can watch and pick up and get information on. It's always good.
I think it's really important, to the safety of the patient.
Stop. There we go. So we're dealing with safety right now. And, yep, NHTSA gathers near misses, characteristics of crash. Can you believe that 64% of us still do not wear our seatbelts in the back? And they are recommending that if we unbuckle, that we have our partners stop the truck. We don't go any further in. There's times if we didn't get up and move around with our seatbelt we didn't get up and move around, we wouldn't have patient care. But there are special crash investigations. Once you crash an ambulance, NHTSA will send out a special crash investigation, which will get a deep analysis of the crash, and they will get your black box, and they'll get everything because they want to know what actually happens. And they're going to want this minimum uniform crash criteria, which the state police does not use, but has to when NHTSA gets involved with a crash. They participate in monitoring ambulance defects that causes crash. They do promote this national strategy for EMS culture of safety. They also provide ground ambulance standards. And I think both of these I just opened to show you. Average 4,500 crashes a day. 1,500 of these injury crashes injure approximately, the 1,500 crashes, 2,600 people are injured. 59% are in emergency use. So when you turn your lights on, that does not just protect you. 59% of these crashes occurred, while they were in emergency mode. 29 fatal crashes with 58% of the emergency use. Now, 42% were non-emergent. Of the fatalities, 4% were the driver. All right. So if you're driving an ambulance, you got a good chance of not being hurt. 96% chance you're not going to die in a crash. 21% were ambulance passengers. So, that's good. But 63 were occupants of other vehicles. Our trucks are heavy and they create havoc on lighter vehicles. And 12% of them were pedestrians or non-occupants got killed. 12% got killed outside the vehicle. Of the injuries, 17% were the driver, 29% were passenger, and 54 were in the other cars. So there are data, but now there are some limitations to this data. The crashes occur on roadways customarily open to the public, and not all vehicle crashes in the country are reported to police. And police may not record ambulance
accurately on the crash report. A lot of times, police will mark us down as a custom van or a modified van or a camper van, or they don't know how to classify them. They don't distinguish between ambulance types, type 1, type 2, or type 3. um, it doesn't get all the data showing the proportional time an ambulance is on the road. So does not concurrently differentiate between the occupants, a passenger seat or patient compartment of the ambulance. It just marks out where they're at. So with this model minimum uniform crash criteria, they will improve the data collection, and therefore we'll have better data, and with better data comes better analysis. Um, these are the ground control by tracking. Let's see if this comes up. File is not found. Okay. And let's see, is this information here that we can see? I think this is off of the video that we were looking at earlier. And that's also an error. Okay. So we can't see that. But that is where 84% of were unrestrained EMS providers. 84%. That means what? 16% were? Think about that. 16% are the only people that's riding around. Now, they have changed the ambulances set up in the back. In fact, New Orleans EMS down in New Orleans, they've actually got it where their paramedics can sit in the back of the truck and reach 99% of their equipment. They can work on the patient and never get up and become unbuckled. They have 5-part harnesses they put on and are going to be able to be secured. 33% were secured by both restraints, their shoulder and lateral restraints. 33% were secured by both. But if 33% was secured by both, then that's 66%, 67% that were not secured by both restraints. 44% of the patients were ejected from the cot in serious crashes, so they got crumpled up over in the step well. 61% of the patients were restrained with just lateral belts only. So lateral belts only work real well if you roll over, but if you get a crash from the front or the back, you're not going to be restrained. They're going to be sliding. And 38% had shoulder harnesses available but unused. If you got it available, why not use it? I don't understand. We need to evaluate the policies and procedure at our service, how it relates to protection of patients. Some of y'all do a great job at documenting lap belts and shoulder harnesses applied to the patient. They're put on the cot. We need to make sure that we follow good science when we're hooking these seat belts up, making sure that they are restrained because it reduces the risk of patient injury. We need to look at our guidelines supporting that. I don't know if they're in the policy and procedure or not, but we could look. I don't think I remember seeing them. And what's some recommendations you might think of that might reduce the risk of injury in a crash?
Situational awareness.
Yeah, situational awareness. Knowing that if you're on the roadway out there and going straight down the road and everything looks good, maybe you could unbuckle and move around a little bit. But if you're in town, you better have your tushy in the seat because in town is where most of these accidents occur. Situational awareness. Anything else you can think of? Anybody ever survive an ambulance crash? Y'all got quiet again.
I've never been in one. I mean, lots of people survive them.
Yep, they do. But go ahead.
You open yourself up with some strong legal liabilities when you have an ambulance crash, though.
You do.
And it's always the ambulance's fault, even if it's not the ambulance's fault.
Well, because we're given special dispensation to do things at different you know, like going the wrong way up a one-way road, driving faster than the posted speed limit. We've been given all those criteria, but we got to understand that we must do that traveling with the ambulance. We must do that within with due regard for other persons on the roadway. And that is the big thing right there. Due regard. And if we don't do it with due regard, then we are opening ourselves up to liability. And due regard is simply stated doing what's right for the other people on the roadway. You know, we run up behind somebody, we're blowing our siren, and there's no place for them to go. All that siren is doing is creating problems to the patient, the person in front of us, to do something stupid, like in a road construction, pulling to the right when they can't pull to the right because they've dug out a big, huge crater. You know, uh, having them leave the roadway and lose control of their vehicle because we wouldn't, running our siren behind them. We never take the road. We always ask for the road and then try to use our siren to help us get through that. So there's times that our siren's asking permission. If they want to push it, we're not going to push around them. It's up to them to move for us, not for us to move for them. And I guess that's where you come into the fact that what you said earlier, that it's always the ambulance's fault if something happens and we having that crash occur.
Right. I mean, until it's investigated and a fault is determined by law enforcement, even then, a lawyer is still going to try to tear it apart. They're going to ask and say, or they're going to investigate and say, were they driving with due regard? And sometimes we're not. I mean, like you said, we're asking for permission to pass. Although laws have changed now to where, law says you have to slow down and move to the right. If you can't move to the right, well, you're kind of just stuck.
You slow down and still pull as far to the right as you can to let the vehicle go around. We should never be passing people on the right side in an ambulance, because if we're running an ambulance on a multi-lane road and we try passing them on the right with lights and sirens, if I'm an old guy, which I am, and I hear the siren and I start to pull to the right and you're on my right and we crash, guess whose fault that is?
The ambulance.
Yep. Because you're passing me on the right, and the law says if I hear an audible siren, I need to pull to the right.
You do get those people that will not pull to the right, because there's been a handful of times to where I have had to pass on the right, but not instant. I didn't just come up and then go around them. I got up behind them, sit there, and it will not yield. You have no choice but to go around. I mean, it was but it wasn't like in a bad spot. It was a, good flat road, open, made sure everything was clear. And, I took my situational awareness into consideration, but it's only happened a couple of times.
Yeah.
Since I've been, doing this. But what really gets me are the people who stop right in the middle of the road in a blind corner. Yeah, that happened so many times.
That's Missouri. Missouri people will stop in the middle of the road, and I don't know why that is. I think that is the way their law is written. I've actually run into the back of a car on the Mississippi River Bridge when the vehicle stopped in the fast lane on the Mississippi River Bridge, and there was no place for me to go except into the back of the car.
Yep, and there's a lot around here that even if we've got 2 lanes of traffic heading northbound or southbound, whichever, instead of moving to the right, I mean, you're not even pulling over, but just moving into the right lane. Instead of doing that, they'll move to the left into the center lane and, not supposed to be passing on the right. That kind of forces us into, or can force us into oncoming traffic when that shouldn't even be an issue when there's 2 lanes of traffic going the direction we're going.
That's a no-win situation.
Right. And then, with due regard, if we're practicing due regard for everyone else around us, that is also due regard for ourselves.
Oh, yes.
I want to get there. I want to get home. I want to be safe. So due regard goes both ways, because if we're giving everybody else the cushion and that, and not trying to cause them to do something stupid or, cause harm to them, that also keeps us safe and unharmed.
True. Now, what does North Arkansas Regional Medical Center do to help reduce the possibility of you having an ambulance accident?
EVOC
training, and that brings you back to your situational awareness and actually driving the vehicle and under these simulated situations, looking ahead, teaching you what to watch for when you come up to intersections and come up to different situations, and trying to do what's right. And that's what we need to be doing. And EVOC is a good thing, and I concur that everybody takes it, and it's good for us. Okay. Now, anybody got anything on ambulance, culture of safety, ambulance crashes? Yeah, they fillet. If you don't believe that there's some good footage out there of ambulances going down the road and people doing stupid stuff in front of them.
I call that code 3 switch the stupid switch.
Yeah.
Because a lot of people stupid.
There was a artist's rendering of what an ambulance actually said in the front. It says, do something stupid, slam on your brakes, yeah, that all happens. Okay, let's move on to field triage. What do we use for triage? What is our uniform model for triage and mass casualty in the field? Did you know they had a national implementation for that? From 2013. And it listed 24 core.
I can't remember what it was a system. Of course, it uses the red, green, gray, black, yellow system.
The
START is the big one, right? That's
START,
the one.
yes.
That's the one that Arkansas has adopted, and it's really simple, and that's not it. And it can also be used like SORT. SORT is the same way SALT. It actually can work. Let's see. That's the START, and that's the SORT. That's not it right there. Contrary to popular belief. Well, maybe it is EMS training. Yep. No. I hate that. And you can't reach it. So there you go. Never mind. But yes, they use the rapid triage for MCI. And what they do is they use the red, green, yellow, all of those. Okay. Hang on. What's going on here? There we go. And you all know that whatever we're using RPM. That's our three things we look for. When we use START, we use RPM. We use SALT, we use RPM. We use Jump Start, it's an RPM. That's respiration, pulse, and mentation. We want to make sure that we follow those. The basic step to all of these triage is, where do you start your triage? You pull up on a scene and there is two charter buses run head on into an alcohol container. Where do you start? Where do you start with triage? It's where you stand. It's where you stand. If you pull up on the scene and you get out of the truck, that's where you stand. That's where you start your triage. You start triage before you ever get on the scene, as you're using the windshield to give you your feedback of where you want to set up your command post, because you suddenly become incident commander of this mass casualty incident. Uh, One of the first things they teach you in triage is to get on your intercom or your PA and say, all of you that can walk over there to that tree, or walk over there to that house, or walk over there to that building. And what that does is it gets those green walking wounded away from your scene. And the green is going to be the majority of them in most situations. You're going to have more walking wounded than anything else. If they're walking, do they have respirations? Yes. Do they have mentation? Yes. Do they have a pulse? Of course. So that is the three things we're checking. So those guys have moved out. The next thing you do is you start going to the scene of the less little people that's there, the smaller number, and then you start going through the RPM, respiration, pulse, and mentation, and you either tag them as immediate, which is red, or delayed, which is yellow. So they're either good in red or yellow or black. Black means we're not going to deal with them because they take too much resources for us to save them. Is that how y'all understand triage?
Yes, that's how I understand it.
Yes.
Okay, because I thought maybe for a minute I was
Yep.
off base. So, respiration, pulse, and mentation. Those are the ones you're looking for. With salt, they do this a little bit differently. Obvious life threat, purple with some movement and walk. Um, but the red ones get out of here as soon as we have trucks available. The yellow ones can be a little bit delayed and they can go out. The green ones, we can order school buses for them to go because they're walking wounded and they're not going to be needed to be seen at our local stuff. Okay. The good part about start using respiration, pulse, and mentation, if they're pediatric, we can still use respiration, pulse, and mentation. They can still be categorized by yellow. So the colors again, red means what?
Critical.
Critical. We're going to, if we don't do something for them now, they're going to die. So we got to get them taken care of. Yellow means they can be
Delayed.
right. And then green means they are
Walking wounded.
and
Walking wounded.
black means they are
Dead.
Dead.
Dead or they die.
yeah.
DRT.
DRT, dead right there. Any questions on triage?
No.
No.
Negative.
Okay, next part. Does anybody need a break? Good. Let's move on. Um, this next part is called proper hygiene, safety, and vaccinations. The number one thing to help cut down on diseases is simply doing what?
Washing your hands.
Yeah. Wash your hands. We have dispensers in most of our trucks, alcohol dispensers, foam dispensers. You foam in, you foam out. So foam yourself into the patient contact area, foam yourself out. Wash your hands before you have patient contact, after you have patient contact, before you eat, after you eat. You know, we touch some mighty nasty stuff out there, and we shouldn't be eating if we don't wash our hands because we can get our hands into some really bad stuff. Clean the ambulance and equipment. Uh, Before and after, we should wash our hands. After using the restroom, wash your hands. After blowing your nose, coughing, or sneezing, you should wash your hands or at least use the hand sanitizer. Avoid touching your eyes, avoid touching your mouth. Follow your CDC guidelines for hand washing hygiene. I wonder if this website is going to open. I'm so sorry we're keeping you awake.
Sorry about that.
It's okay. Yeah. And hand washing, you wash it and you read you say your ABCs, and that's part of it. As we keep our hands clean, remove your jewelry, wet your hands, apply your soap, scrub your hands, the back underneath your fingernails, rub it for 20 seconds, rinse your hands under running water, and then you dry hands with a towel and air dry, and then turn off the water using the towel. If you got alcohol sanitizer, it should be at least 60% alcohol, if not 90. It doesn't actually sterilize your hands, but it does reduce the germs. It does not eliminate all germs. It does not kill viruses. Let me say that and again. It does not kill viruses. So alcohol can sanitizer does not kill COVID-19 because COVID-19 is a virus. But now alcohol does create an in-hospital environment for viruses to live. Alcohol wipes, alcohol-based hand sanitizer doesn't do well if they're visually dirty. If you've got patient uh, excrement on your hands, using the hand sanitizer won't clean it. Uh, know that soap or water is better than hand sanitizer. Put it in one palm, rub it together, rub all surfaces up around the wrist, and then as soon as water and soap is available, wash your hands. That's just the best way to go. Um, eye and face
What
protection.
about sandy wipes?
Sandy wipes? I don't know. What do they say
Yes.
about sandy wipes?
About the purple tops?
Oh, yes.
Those accordingly
That's what I'm talking about.
give you cancer. They're not supposed to be used for skin contact.
Well,
supposedly.
I would rather have cancer than somebody else's.
Somebody else's what?
C. diff.
Okay, there you go. But death from C. diff, death from cancer, they're both a bad way to die because you eventually do die.
Well, I mean, everybody dies, so.
Oh yeah, there you go.
Might as well, determine how you're gonna.
That's true. Eye protection is recommended by CDC workers when they're acquiring around an infectious disease, Hep A, Hep B, strep, herpes, adenovirus, HIV, rhinitis. Wear your eye protection, goggles, face shields, safety glasses, and full face respirators. What is that thing we've got out there? A CA?
Capper device.
Capper, CAPR.
PR, I think.
Yeah.
Max Air.
Max Air.
Yeah, capper device.
Yeah, I did the air training on that. That looks awesome. I think I'd like to wear
It is
one.
fantastic.
Hey, Greg, have you used one yet? 'Cause I know whoever got them.
I have. I have got to use one, and it is absolutely amazing because not only are you not fogging everything up with a regular mask, you have constant fresh airflow going into you, so you get to breathe good air and not be worried about whatever else is out in the air.
Is on, of course, you don't have to worry about working down there in Searcy County, but like long distance transfers. We've got a problem with MEMS calling us about once a week for take homes from Little Rock that are positive. And they were like, yeah, it's like, well, you think most of the time they don't do it is because they don't get no money out of it. But no, the last couple ones they have were payable. They just didn't want to deal with it. But anyway, so the other day, I don't remember what supervisor was on. They're like, nope, not going to do it because the basic truck didn't have a capper device, as far as I know. So they're starting to make it to where if we have any long distance transfers, that we're not going to do it unless they have the proper equipment, aka capper device. So Greg's right about that. Me and Morris, when I worked for Pafford, me and Morris took a long distance from Rogers all the way down to the other side of Fort Smith, and it was absolutely miserable wearing everything in the back of that truck like that.
It would be. That capper looks like it'd be a neat thing to have good, clean air to breathe. There are times I wished I'd had one back in the early days, but they didn't have anything like that back in those days. So, vaccinations for healthcare providers: Hep B, yep. Influenza, yep. MMR, yep. Varicella, yep. Pertussis, yep. And then vaccines for disaster response. What kind of vaccines are we talking about for those?
Are you talking about the vaccines, like if you're going to like
Africa,
over in Haiti and stuff like that? Those vaccines, those
Right.
inoculations.
What are they for?
Malaria.
Sure.
Any other kind of communicable
Typhoid.
disease?
Yeah,
Typhoid.
Yeah, big one. That's cross-contamination with fecal material. Yeah. And then the other one that's not listed here, strangely, vid-19. Probably will go to this recommended vaccines. But it does say that this list is not exhaustive, meaning there's other things you may have to have. All right. So why do we take a vaccine?
To reduce the risk of infection to yourself, or if, like with the flu shot or the flu vaccine, it's not necessarily going to reduce the risk, but it is going to help you get over the symptoms quicker.
Okay. And some of these mimic the disease. They produce antibodies in the blood. Some produce antibodies directly, and some are attenuated or weakened or kill viruses. Which one of them is that COVID-19 that we take?
it is the mimic, right? mRNA.
Yep, mimic. That's it. And it produces the antibodies. So it's neat. Once you get the virus, the vaccine, if they pull the antibody test on your blood, then it will show up in there. Okay. Comments, questions? Culture of safety is coming next. Is safety a big thing for us?
It's getting to be more and more of a big thing for us. I think a lot of the times in the past, it's been just kind of something that's put off. Yeah, we try to be safe, but I think with the times that are coming, especially with the increased violence, safety for EMS firefighters and it's getting up there. It's becoming a more and more prominent issue that is being looked at more in depth now. I think certain ambulance services have actually started carrying or requiring, bulletproof vests to be worn as a safety precaution. You have a lot of abuse in the back of an ambulance or even in the hospital setting between patients and nursing staffs or including paramedics and stuff in the back of an ambulance. All it takes is a patient thinking that they're bigger and stronger, and all it takes is them to just do what they can to try to overpower you, and you're at risk. So we're looking at better ways to restrain and keep an eye on the patient as well as protect ourselves.
Well, this goes back. This strategy for EMS culture of safety started in 2013. So 8 years ago, this strategy was put out there. And some people go, wow, I've not heard of a strategy for national EMS culture of safety, but it's been out there since the 2013. And the National Association of EMS Educators, the National Association of the EMS Medical Physicians, ACEP, NHTSA, and all these other agencies are out there trying to get this implemented. And what they want is develop environments in which EMS personnel are safe to report errors, focusing on various factors that contribute to errors, and risks in order to identify means of overcoming factors that contribute to errors. So that's one culture of safety. And then the other part is dealing with coordination of things that do occur to us out there, slips and falls and that sort of thing. And we've got to be able to have an EMS safety resource center where we can create guidance and resource coordination. And that's coming back to that ems.gov, which we looked at a while ago, and I'll look at it one more time to give you an idea. This is the National Clearinghouse, and when you look here at safety, this is the EMS workforce safety. That's one of them that's out there.
and they have guidelines for the adoption of EMS workforce safety. Yeah, we want to go home at the end of our shift, and this is put out by NACISMO, National Association of EMS Systems officials. This is our people that work for state health, and this is the supply workforce, the demand, the shortages of the workforce, and there's guidelines for essential workforce data, engaging in local EMS agencies, maintaining a healthy EMS workforce, um, understanding the workforce demand. These are all 10 core 10 for the guidelines, uh, and some of the stuff that's out there that leads to this culture of safety. And uh, I thought this one was neat. Page 13 here actually got into occupation, paramedics and EMTs, mean hourly wage $16 an hour, median hourly wage $14 an hour. And then if you look at LVNs and LPNs and firefighters and sheriff's patrols, we kind of the lower end of that. And wage is part of it. That's just part of it. That's not all of it, but it does all come into the vision. And they are looking at developing a health and safety wellness for the EMS workforce that deals with our workforce and wellness, education, certification, planning and development, and data and research. And all of these parts are coming together to provide us a safer workforce. Um, this is a great pamphlet to read. It'd be a great pamphlet to print out and leave around the ambulance service in case somebody picked it up and read about it. Uh, it's got some good statistics and good information in it, and it was generated by the workforce, as we said, the culture of safety, and talking about the way things should be. Um, there you go. Um, they one of the things that they did out there was the EMS safety data part, and that somebody just sent me something on the EMS safety data where they actually are reporting near misses, and near misses are basically where we've had parts of it go bad, and how things are, how we can set up these data sets to help point it to the general public, injuries, illnesses, and incidences that occur, and certain surfaces, certain ways that we respond in the hospital or out of the hospital. You know, that's why we wear those green vests. Everybody likes those green fashionable vests we wear, but they were part of the safety initiative that was put out there. And we need to educate our people with a more understanding to safety in mind, because we're not. And we need to develop safety standards. And this EMS SRC is the agency that deals with a lot of that stuff. And yeah, creating a culture of safety. This is EMS World. Here's the EMS Gov. This is the draft of that one. And then this is EMS.gov. And this is strategies for that safety part again. This looks like a white paper they wrote because it looks like it is a white paper. Yep, and you can go through here and look at all that, and it looks to be several pages lean length, but it is a strategy for us. Comments, questions? Fatigue in EMS is a big thing that's going on out there. Um, they have found that if you work a 24-hour shift, 12-hour shift, that if you drive home after working a 12-hour shift without taking a respite spell, then you can be as impaired as somebody who's drank 3 beers. Have y'all put me on hold or pause or something?
Hey, I was just say a lot of places are putting in sleep rooms for people going off shift.
Yeah, sleep rooms.
That's kind of a cool idea.
Yep.
Interesting. I would never think that.
Well, I can look you right here at conclusions.
I would never think that, but then again, Bryn she does very questionable things.
If fatigue is a threat to the safety of AS personnel, the patients, and the public, there is no equivalent effort from any high-risk industry occupation to improve worker fatigue. We don't let truck drivers drive beyond 12 hours. We don't let airplane pilots fly below 12 hours, but we're going to let people who drive ambulances drive 24 hours? Yeah. This body of work may also inform other high-risk entities to depend on workers' shifts and struggle address fatigue within the strategies based on the evidence. And yeah, there is some interesting stuff I hear that's listed in this on fatigue. Performance measures, how we rest, and you're right, sleep time. You know, somebody says, well, firemen work 24 hours. Well, firemen work 24 hours, but what? You know, they're not up for the whole 24 hours. They are sleeping some. And this is part
And they're also not driving long distances.
I'm sorry, say again.
You know, they're usually not leaving their service area.
True.
Polar.
Cody, do you have something else you want to say?
No.
Okay. All right. But that's fatigue in EMS. And what's going on with that and how you can help and what you can do, that's out there. And these are the projects that they're involved with this NHTSA. All right. So steps here again, mandated reports, safety reporting are necessary so common language and data can be created, determining what data is already available and can be mandated, determining data that's useful, learning from the hands-on experience, assigning authorized investigative party, and identifying and existing best practices. In other words, finding out what's best. And we're looking at not only best practices, but we're also looking at evidence-based for things to do. All right. So what changes are needed to encourage the development of a culture of safety at North Arkansas Regional Medical Center? Do I need to turn off the recorder to get y'all to talk?